Ms Carey.
Good morning, my lady. The first witness today is Mr Vaughan Gething. He is appearing via video link and he will affirm.
Thank you.
Good morning, Mr Gething. I'm the usher that's going to be taking you through your affirmation this morning. Can you see and hear me?
I can indeed. Bodadar, good morning.
Thank you. If you could repeat after me, please. I do solemnly, sincerely and truly, declare and affirm that the evidence I shall give shall be the truth, the whole truth, and nothing but the truth. Thank you.
Mr Gethin, thank you for coming back to help us again.
Bodadar, my lady.
Mr Gething, good morning. We have a number of topics to cover this morning. I hope you have in front of you a copy of your statement 474252, to which we will be going at various points in the evidence. May I start with some background? I think you are a lawyer by background. First became a member of the Senate in May 2011, and 5 years later, in May 2016, became the Cabinet Secretary for Health, Wellbeing and Sport, which in due course in 2018 became the Minister for Health and Social Services. Is that correct?
That is correct.
And you remained the Minister, I think, until the 13th of May 2021.
That's correct.
All right. In your role as Minister, there are responsibilities set out at length in your statement. I'm not going to go through them all, but is it right that in October 2020, your ministerial responsibilities were added to include the COVID response, screening, vaccination, and some other responsibilities?
That's correct. That formalised what was in practice happening.
Quite. All right. And you are there to set the policy and strategy and, to use your words, hold NHS leaders to account.
Correct.
Now, we know that in Wales, you discharge your statutory duty by delegating that to a number of the NHS bodies, including the local health boards, who are responsible for the operational decisions. Is that correct?
Correct.
All right. And we've heard from Dr Goodall about the power to issue directions, which, as we understand it, are mandatory. But he told us they were mainly financial. Is that correct?
Correct.
All right. Now, can I ask you, please, you say in your statement that in April and May 2020, you met with NHS chairs and chief executives to hear about their challenges. Can you help us, please, with some examples of the things that they were telling you?
So there are a number of things, both about how they'd had to reorganise services to ensure the service didn't become overwhelmed. You'll recall I'd made a statement on the 13th of March, so some of it was about what had happened since then. A lot of it was about the current situation. So that's not in terms of operationally what they were doing, but a large part of their concern was about staff welfare and well-being and what was coming next, because we still didn't know a great deal at that time. So people were living with fear, both in the wider public and indeed in our health and social care services.
You say in your statement that you feel you had sufficient understanding and knowledge of the challenges facing the NHS. Clearly, those meetings were no doubt a part of that. How else did you gain that understanding?
Well, in addition to the concerns that chairs and chief execs had and the conversations I had with Dr Goodall, I had conversations with Dr Atherton, I had conversations with the chief nurse and the chief scientific advisor on health. Royal colleges, including the Academy of Royal Colleges, and trade unions, including the RCN and other trade unions in partnership. So issues that we may go on to around PPE, for example, around what was happening with testing, those were things that came up in all of those different fora from a slightly different perspective. And, you know, anecdotes about operational practice. So trade unions would sometimes raise issues where they felt that they weren't getting a sensible hearing from the employer. And so some of that was about making sure those issues were resolved. And often they were issues that just needed people to have the same conversation at the same time. So there are big strategic issues, and sometimes you can get drawn into what seem like minor issues, but I think are important about delivering trust.
Can you give us an example of a minor issue that you got drawn into?
Well, there was sometimes just about individual workplace practice. and about whether people who were running the organisation understood the impact of that on their staff. So Unite and Unison raised those examples. I gave an example in my statement, actually, about where Unison had an issue at the Welsh Blood Service, where actually the issue about members of the Welsh Blood Service not using their gloves all the time was actually what their members felt they should do. And that was something we wouldn't normally have expected the minister in the middle of a pandemic to get engaged in that. But that was about a feeling of trust and people being listened to. And sometimes if you don't deal with those, they can accelerate and become a much bigger issue.
Right. I think you also held monthly meetings with the Welsh Ambulance Service Trust, because in both pre and during the pandemic, clearly there was a pressure on the flow through emergency departments.
That's correct. I had, since I became the Cabinet Minister, I'd held meetings through the winter to understand both before winter where we were, in the winter, then towards the end, because that is a time of extraordinary pressure. I know every year people say there aren't winter pressures, it's year round, but every winter there are even more extraordinary pressure. And the ambulance service really were on the front lines throughout the pandemic.
I think you are aware that the Royal College of Emergency Medicine have provided the inquiry with the statement, and there was what is said to be an absence of meetings between either yourself and the Welsh Government with the Royal College of Emergency Medicine. Can you help Mr Gething as to why you didn't meet with that Royal College?
Well, I had meetings for a purpose, as did my officials, and the other thing it's worth pointing out is we had a clinical lead on emergency medicine who at the start of the pandemic was also the Vice President of the Royal College of Emergency Medicine for Wales. The meetings with the Academy of Royal Colleges included the Royal College of Emergency Medicine. I think about evidence from Frank Atherton about his meetings with the Academy of Royal Colleges as well, again, including the Royal College of Emergency Medicine. I don't ever recall receiving a meeting request from the college to discuss a particular issue. Whereas, for example, when I met the Royal College of Surgeons, they had a specific request about wanting to restart elective activity, but to do it in a way that took account of where we were.
May I ask you briefly about control and command structures?
Sorry, Milady, we've lost the...
Yeah, my lady, I've lost Mr Gething on my screen, but we can see him. It may be that all of council's
Can the
rows...
private gallery see him? Oh. But you...
Forgive us, Mr Gething, one moment.
Mr Campbell, you can't.
We have a technical issue.
They're working on it. Working on it.
We can hear you, but we just can't see you on everyone's screen.
I can assure you that's the only thing.
Is there any way we can find out if those following on YouTube can... Because if people at home watching online can follow, we could probably carry on if people will forgive us.
You're back now.
Excellent.
Can you see and hear me all right?
I can indeed.
Sorry about that, Mr Gethin. Technology is wonderful when it works.
Indeed, indeed. Dim problem.
All right. I think we were just dealing with the other meetings you had in the absence, you say, of a particular request from the Royal College of Emergency Medicine, and I was moving on to command and control structures. All right.
Yes.
The Chief Medical Officer for Wales has commented that even when he came into post in 2016, there was a report which suggested there was insufficient ability to have a command and control arrangement within Wales. And he said that had bubbled around ever since, and it was certainly a feature when COVID hit us. Dr. Atherton went on to say that although he was not critical of the NHS executives, he thought that in fact there needed to be a stronger guiding hand and a move away perhaps during a pandemic from the collaborative approach to a more directive approach. And can I ask you, Mr Gething, do you agree that there was insufficient ability to have a command and control structure which was sufficiently directive?
Well, the problem is this is one of those challenges in running a whole system. So you can't make every decision from an office in Cardiff Bay, but the reason why the NHS executive for Wales was formed was to have a more central approach. And this was often actually about service change and transformation, which is actually extraordinarily difficult. And you always get people arguing against local service change because they fear the loss of something rather than demanding service change because a better service could be delivered if only you'd reorganise it. So it was really more in that sense. And when the pandemic came, the collaboration and the directives that came, the Welsh Government made a whole series of choices and convening that it wouldn't have done in normal times. I'm sure there are lessons to learn about areas where we might have wanted to be even more directed, but I think the main lessons are likely to be things we'd want to do differently.
All right. Can I ask you potentially about an area where you may be more directive? By the end of March of 2020, the waiting lists for non-urgent elective care were higher than they had been the previous year, and inevitably you knew were going to increase because of the decision to suspend non-urgent elective care. One of the experts in the inquiry, the HIPS experts, said that delay, obviously, in restarting surgery has resulted in not only the pain and disability, but for some people, a real reduction in their quality of life. And that waiting times now in Wales are consistently over 2 years. And they made this observation, that whilst there was the decision taken to cease elective care, there was no top-down mandate or direction in Wales about how the trusts and boards should restart routine elective surgery. Was any thought given to directing the boards to resume a percentage of their pre-pandemic non-COVID work?
Well, the frameworks that were issued, the operating frameworks that were issued after the first wave, were actually about getting elective care restarted. I know they're covered in my statement and Dr. Goodall's. So actually, those were directions issued about having an operating framework. The challenge was we issued those frameworks when broadly the situation was much better than the first wave, and then everything got substantially worse through the autumn and the winter. And the challenge always, and this comes back to why when you talk about service reform, you're dealing with inconsistency in delivery, you're dealing with very local models of care and how you get greater consistency and efficiency. And with respect, I don't think those things are linked to the pandemic. I think those things are about a more general challenge in delivering health service transformation and reform, as opposed to the choices we made directly in the pandemic.
Yeah, the quality frameworks of which you speak did obviously urge the boards to restart, but it never said to them, do 50% this month, 60% next month, or add 100 every month. And I think what the experts were saying is it perhaps needed that particular direction being given to them to help encourage, if not enforce, the resumption of non-urgent elective care. That's what they were getting at.
I'm not sure that works in practice. If you want to, for example, think of the evidence of Phil Clure and Glangwili Hospital and the networks they had there, compare that to the evidence of Professors Walker and Jenny in UHW, you're operating in quite different context. Yes. And if you have a surgical team of 6 people and 3 of them are on the clinically vulnerable list, telling them they nevertheless need to get to 6% efficiency isn't realistic. So that's part of the challenge in understanding the different centres you have, how they operate, and the context for that. And that's why health boards are responsible for delivering those operational choices. Nobody wants to under-deliver on performance in this area because in normal times, you understand, people live with discomfort if they don't receive potentially life-changing treatment. Even more so, given what happened in the pandemic.
Right. Can I ask you this then? What did you do as Minister to ensure, forget a lack of percentage or a direction that they must do X thousand operations per month, what did you do to ensure that they were actually fulfilling the advice and direction you'd given them to restart it as soon as they were practically able to?
Well, after the frameworks were issued, you still have the regular meetings with chairs and chief execs, and we did discuss what they were doing on restarting that activity. The problem is, after we issue the frameworks, COVID starts to rise significantly. So our ability to restart the non-COVID part of it actually gets more compromised. But by then, and again, you see this in the evidence from Phil Clure and the respective medical directors for Cardiff and Vale Health Board and others, you are starting to see the ability to try and have segregated red and green lanes as well. So you're trying to, and this was again something the Royal College of Surgeons urged, to try to have, if you like, a green zone where you can try and undertake this more elective activity with a backlog that we know is building up, and a red zone where you know actually you've got to take more precautions, and that means your efficiency is compromised.
Can I ask you this? Do you think that in a future pandemic, there should be contingency plans which include a strategy or a plan, call it what you will, for either the continuation of elective care or at least the prompt recovery of it?
I think it's helpful to try and learn lessons from what worked well here and what didn't. And the challenge is you have to go back to what's the scale of your challenge at the start? How can you then operate safely in elective areas? And a pandemic might not be this one. The challenge of having enough testing and understanding how you operate safely and the estate we have are things at the time. But to understand how we got to restart at this point and what we might do better, I think is definitely well worth learning to try to understand how we don't simply accept there will be a very large backlog and there is nothing we can do about it.
Yeah. Can I ask you then about some of the challenges? In your paragraph 58, you make the observation that your primary focus was to save lives and protect the NHS. Can I ask you, what did you mean by the phrase protect the NHS? It's your paragraph 58, Mr. Gething.
Yeah, I think we're really talking about, and this does go back to, I gave this evidence in Module 2B as well, what had happened in northern Italy really affected me. A first world country with a first world healthcare system that was plainly overwhelmed, with people lying in corridors in a way where the care was neither dignified nor appropriate. And that really bothered me. How do you make sure that doesn't happen? It isn't just about those individuals. I think that would have a much wider shock and impact in wider society outside the health service as well. So I was always concerned to make sure that the NHS didn't get overwhelmed in that way. And that meant that we had to turn off parts of the NHS for that to happen. None of that is comfortable and none of that is harm-free, but a much greater harm would have been what we saw in northern Italy.
What did you understand that the NHS overwhelm would look like? No more beds, no more ICU beds, no GP appointments. What did it mean to you?
Well, I thought it could mean everything that we'd seen on our screens. And it's hard to overstate how shocking some of the predictions were about what might happen. If you really can't have intensive care beds, if you really have people who need and would benefit from invasive ventilation, you can't do it, then more people die than potentially need to, and they die in a very undignified and harmful way itself as well. And that then has a ripple into every other part of the service. If you look at what we did, there was a ripple into every part of the service as well. If your main part in the hospital system can't cope and is overwhelmed in that way, that ripple is even more significant, and we'd have lost more lives from the public and from our staff as well if that had happened.
So do I understand you correctly, do I understand this correctly, that for you, if someone didn't get an intensive care bed or wasn't able to be put on a ventilator, that would be an indication that the NHS in Wales was overwhelmed?
It's an indication it's being overwhelmed. In normal times, you have challenges on staff ratios in some services and they're operating under some stress. What you'd have seen if the whole service was overwhelmed was that you'd have seen large numbers of people not being able to get appropriate care, including people where the NHS could and should be able to act to save their lives. Now, that was the nightmare scenario, because actually the harm done to staff who are going into work in those situations would be even more significant than the harm that we know that our staff are living with now from what did happen.
Well, we'll come on to look at the impact on staff in a moment, but can I ask you this? Do you consider that during your tenure as Minister, the health system in Wales became overwhelmed at any point?
No, but that's only because we took extraordinary measures. If we tried to run the system as normal, then it would have been overwhelmed. That's why we had to take a measured process to turn off parts of the service and to change it to allow the system to still function, and in particular those people with the extraordinary need that we saw in both waves 1 and 2.
Can we have a look at some of those measures during the course of the next part of your evidence? And can I start with the framework that you published on the 13th of March? And perhaps if we could have a look at your paragraphs 108 and 109 in your statement, Mr. Gething. Could we have on screen, please, 474-252_32? If it helps you, Mr. Gething, we've got them on the screen.
Okay, great.
Okay, the framework there was published at 4 o'clock on the 13th of March. it set out a number of recommendations for action, which included the suspension of non-urgent care, the prioritisation of using non-emergency patient transport services to focus on discharge, expedition of discharge of vulnerable patients, and a number of other measures that we're familiar with to all try and plan for what was thought to be coming down the track. Is that it in a nutshell?
Indeed, it gave shape to some of what was happening.
Now, can I ask you this? Why was this framework not made as part of a direction, but was in fact just essentially recommendations for local health boards as to how to respond?
I think that underplays the significance of doing this in any event. We had a real discussion about whether I should simply direct people to do this, or whether it was preferable to issue a framework to allow this to happen. And that again comes back to the different contexts that health boards are operating in. Again, I know Phil Clure indicated that in West Wales, the pandemic arrived a little later than in East Wales, for example. So the measures taken in different health boards were different, but also if you look at North Wales, North East Wales and North West Wales, they'd have needed to do different things to get ready for what was happening, and that was in the same health board.
Right.
So there was a real discussion and consideration of it, but issuing the framework in itself was an extraordinary measure. This is announcing that standard parts of the health service are going to be turned off, and that is not a usual thing to do. I remember the press conference in announcing this and just getting the dawning realisation of how significant this is going to be.
I follow that. You don't want, for example, a West Wales hospital that hasn't been hit yet suspending elective care before they absolutely need to. So is that an example you would say of why you don't make it directive, but you gave this as a framework as opposed to a mandatory order to the boards?
Correct. The situation in West Wales will be very different from Gwent, very different to Gwynedd. So if you try and have a one-size-fits-all, then you know you'll make things worse in some parts of the service where you don't need to.
All right. Now, the briefing that underpinned the announcement of the framework included, did it not, a reasonable worst-case scenario that critical care capacity simply was not going to match the level of critical care that was likely to be required in Wales.
Yes, that was one of the very difficult things. At that point, the modelling was on behavioural science and the expected response to the public. So, yes, it was a moment of very real concern for everyone across the healthcare system.
I think briefings and, well, the reasonable worst-case scenarios varied, clearly, but at one stage it was suggested that there was needed to be a 30-fold increase in critical care beds in Wales, and I think in due course the reasonable worst-case scenario in April reduced that to 900 ICU beds required in Wales. And you had, I think you say in your statement, 145 level 3 critical care beds.
Yeah, I can't recall exactly. It's I think there's the adult beds with some for children, but yes, nothing like what we're told we might get.
Do you consider that entering the pandemic with high bed occupancy and fewer critical care beds for the size of the population in Wales meant that the Welsh hospitals had to surge all the more and put them under even more strain?
Well, yeah, there was a huge surge that was potentially required. And if you then go back to the pre-pandemic healthcare system, and I think there's quite a lot about wanting more capacity in more areas, and our bed numbers compared to European comparatives, including on critical care, but that requires investment over a longer period of time, not just in staff, but in the physical layout of your hospital buildings as well. So it did leave us with greater vulnerability than if we were in a better position. I think that's undeniable.
Yeah. I think Dr. Goodall told us that pre-pandemic occupancy was regularly around 100%.
Correct.
All right. How did you ensure that there was going to be sufficient critical care capacity given the vast increase in critical care beds that were needed, whichever reasonable worst-case scenario you look at?
Well, that was part of the reason for the framework. You know, if you're going, and at that point we thought the peak would come later. And I think I said this in my statement, as in others, about a single peak was expected, and we thought we were a good deal more weeks away from the peak than we were in fact. So actually, if you don't take an approach to try to manage reducing other activity in your system, you can't redeploy your staff, retrain them, and actually get all the resources in place that you need. So there'd started to be anecdotal calls from different people, but also, and this goes back to some of your early questions about chairs, chief execs, and engagement with them, a realisation that we actually need to do something that is more significant than sending a couple of people on a train.
Yeah. The framework, though, did not provide a model or an estimate of the number of beds that you were looking to free up or that would be required, did it?
No, because again, that would have been us trying to numerically manage things in a way that would have been artificial. But it was about you've got to turn off lots of this activity to be able to have a plan about how you then retrain people as well. And that was more apparent in, if you like, the 3 Southeast health boards, so Cwmtaf, Morgannwg, Aneurin, Bevan and Cardiff and Vale, because they were, even by the 13th of March, that's where we were starting to see numbers coming we were anticipating to come in. So actually, they were much more interested in how quickly they could flex, but also because the hospital infrastructure in those areas as well, with UHW being the biggest hospital in the country by a long way as well.
Can I ask you this? If you're going into the pandemic with 145 ICU beds and you know that the modelling says you need 900, how are you going to get that surge if you don't tell the boards, we need another 750 beds? You need to provide 100 Cardiff, you need to provide 100 Morgannwg, etc., etc. How are you going to ensure that you're going to get the 900 if you don't tell them you've got to double your capacity or triple it, or you've got to provide another 100 beds?
Well, actually, the planning assumptions around that weren't in the framework, were those conversations that were taking place between Dr. Goodall and the system in itself. So, you know, the critical care network in Wales wasn't unaware of the reasonable scenario assumptions, and that's part of the reason why lots of people engaging in critical care were actually saying you need to do something and do it earlier rather than later to give us the capacity to flex up for what might be coming. So, you know, and I'm sure it's in Dr. Goodall's evidence and in Judith Padgett's evidence as well, because she was a chief exec of an Iron Health Board at the time we're talking about the way in which they understood the need to flex up and to build up their capacity in this area. And that meant you had to turn it off somewhere else to have the bed stock available and, crucially, the staff available to deliver the care. I think the other point about the reasonable worst case scenario, of course, is that that is a reasonable worst case scenario if all of your other measures don't work. And that's the challenge, I think, about your planning assumptions and not being able to assume that everything will work and what the sort of public response is for something we haven't had to live through before.
Right. What I wanted to try and understand was, though, how you were satisfied that there was going to be sufficient critical care capacity. I understand Dr. Goodall's having these conversations, but you as Minister with overall responsibility, how do you know, don't worry, we're going to have enough beds if the reasonable worst case scenario comes to fruition?
Well, there are 2 things. The first is, in normal times, I have regular contact with Dr. Goodall as the Chief Executive of NHS Wales and Director General. In the pandemic, that's then daily contact about what's happening. So there are regular conversations between, and this is part of it. The second thing is, the honest truth is that no one can give you the direct assurance that we can have 900 critical care beds in place by a certain point in time. All of your planning and your assumptions are about how you maximise what's possible, but it's dishonest to say I was assured we would have 900 critical care beds in place by the start of May, because there's so many moving parts. And that's part of the worry in making choices, that even if you make the best possible choice available to you, it's still possible that you could live through the disaster you're trying to avoid.
Did you get any updates as to how the capacity increase was going? Did they say to you, for example, we're 2 weeks now on from the framework, we've got 100 extra beds, or 200, or whatever the figure was?
Well, yes, so I think you've seen some of Dr. Goodall's updates that he provided to me, the daily updates. So that does show that not only was there a daily conversation with him, but I'd look at those sort of figures each day to see what were we flexing, what was coming through the door, what capacity is being created. And so that's happening in real time. You know, I'm sure the inquiry has available to it all the data, and I think they just had examples of it. But there is a regular conversation, including a daily one, between myself and Dr. Goodall.
Yeah, Mr.
I saw more of him than my wife on most days.
We've got more data than we need on most days, I suspect. So I hear you there. All right, but can I ask you this? You say this in your statement, that at no point during the pandemic were bed capacity limits breached in Wales. The highest overall occupancy rate during your tenure was 86% during September 2020. This included critical care beds, acute beds, field hospitals, private hospitals, community hospital beds, but additional surge capacity remained available. Reporting, as I understand it, though, is done nationally. Do you know what the position was in any given health board as to how close or otherwise they were to being full?
Yeah, so I think I set this out in my statement that we know that Cwmtach Morgannwg did get really full, and that shouldn't really be a surprise because when you think about the hospital estate, but also it's the health board in Wales with the largest concentration of least advantaged communities. We know COVID didn't strike communities evenly. So actually there was real worry. So there was, mutual aid move around as well, but that also goes into the harm I'm sure we'll discuss later on for staff at what they're seeing and what they're doing. And the statement that we didn't breach capacity is true, but it comes at a cost because you've had to turn off other parts of the service. And again, it looks different in different parts of Wales. I think Phil Clure said that they never had to move away from 1-to-1 ratios in intensive care, whereas a statement from the medical directors in Cardiff said that those were stretched. And I know that Professor White has indicated that too. So there is capacity, there is a bed available, but actually your resources are significantly stretched and redeployed.
A number of things there, please, Mr. Gething. You mentioned Cwmtach. I think you say in your statement that Prince Charles Hospital in Cwmtach came close to declaring CritCon 4 as they had exhausted all their capacity, but there was still limited capacity in neighbouring local health boards. Were you informed of how close Cwmtach came to the brink? Is that information you get?
Yes.
Right.
And yes, both from Dr. Goodall, but also I'm sure it was mentioned by Frank and his deputy Chris Jones because they were close to the system as well. So the system in Wales is fairly small, and that means that relationships with chairs and chief execs and staff around, it isn't, if you like, the arm's length way that England is managed because it's a much bigger unit.
Yeah. Different sizes, understood. Now, you also mentioned in there, though, reference to the ratios, and you're right. Mr. Clure gave evidence that they didn't breach the 1-to-1 ratio. University Hospital Wales said this: during the first and second waves, ICU nurses frequently worked outside the usual ratio, at a ratio of 1-to-2 or above. In wave 2, there was very limited support staff available to assist. In fact, they'd lost the number of staff from the first wave, which obviously placed on demands. And they said this: very few patients were transferred to other critical care units. Unlike in England, Wales's critical care network is not an operational network. Although they had meetings where they were over capacity, they primarily managed at that hospital through dilution of nursing ratios rather than through transfers out through the whole period in question. Can you help me? What were you made aware of about the state of critical care transfers between either boards or intra-board during the course of wave 1?
So I didn't have a report that said, here are the number of transfers that are taking place. It was a more general, here's what we're doing and how we're coping, and this is what we're doing in having conversations between staff. So I knew that the Critical Care Network would discuss things within its board, but also across Wales as well. And that's the point about mutual aid. It isn't a managed central network, but it is nevertheless a network of people who understand the pressures that other people are coping with. If Cardiff and Vale, for example, had wanted to transfer patients and asked for mutual aid, then they could have done that and they would have understood how to do that. It's about how you cope. And I think that's one of the things I think is really important. It's about how you cope with what is taking place around you. and the various health boards have set out how they did that.
If the ratios are stretched, though, 1 to 2 or above, as they were at the University Hospital Wales, do you agree, Mr. Gething, though, that it is likely people were getting less than optimal care than they would have done pre-pandemic times?
I can't honestly tell you that that definitely did or definitely didn't happen, because in terms of the outcomes and outcomes that you'd have expected, I haven't looked at that. But actually, there's a risk. That's why there are ratios in place to make sure that you can give assurance about the quality of care provided. But I wouldn't want to invent an answer for you, Council.
No, I'm not asking you to either, but we've heard evidence that once you stretch the ratios, inevitably the attention to detail, which is the hallmark of intensive care medicine, inevitably gets diminished. And in doing so, you're not providing the same level of care. It follows, doesn't it, that if the ratios are stretched in the way that this hospital had to do, people are not getting the same type of care that they got pre-pandemic.
Yeah, there's an obvious risk, not just in the type of care with the nurse ratios, but about the outcomes. There's an obvious risk of different outcomes. And that is partly, I'm afraid, what coping looks like when you're flexing up numbers and you have more people who are seriously unwell coming into your system.
So if I understand your evidence correctly, you consider that people that needed intensive care got it, albeit with the acknowledgement it may not have been the same level as at a pre-pandemic time. Is that a fair summary, Mr. Gething?
Yeah, I think that is because, in some parts of the system, the nursing ratios, the ratios of staff weren't the same. And I think it's important to recognise that, actually. Yeah. That that's how our system coped with the extra demand that came in.
Yeah. Can I ask you about one of the quotations given by a critical care doctor in Wales to the research that the inquiry undertook? And could we have on screen, please, INQ 499-523_22? Now, Mr. Gething, this cannot be, and nor is it suggested on behalf of the inquiry, this is necessarily representative. I hope you will take that into account. But here is a critical care doctor who told the researchers, we knew it wouldn't help because we'd come to see what kind of people died of this disease, despite escalated care. So we decided not to admit to critical care, whereas had they had a different illness, they probably would have been more likely to benefit, so we would have escalated. We didn't have enough space to give people a go who had a very remote chance of getting better. If we had had more capacity, we might have been in a position to try. Were you aware of anecdotal or conversations that were taking place that were suggested some people didn't get a chance to get intensive care when otherwise they might have done?
No, and that's very upsetting to read because that's a direct impact on an individual, but also on a staff team who are making those choices.
Do you think there ought to be a mechanism in Wales where that kind of frontline, very visceral experience is relayed to Dr. Goodall, Mr. Atherton, and the Minister, so that they do appreciate that whatever the data says, there are the most heartbreaking decisions being made on the front line?
Well, some of that comes from the networks that do exist. So Dr. Atherton talking to medical directors, I would expect medical directors to be aware of what's happening on the front line. Dr. Clare was a respiratory physician. So, I know that he would have thought about this himself. That's the same position for other medical directors in their specialities. I did know that heartbreaking choices were being made because I knew that was inevitable and unavoidable, but not specifically that even in this anecdotal piece of evidence that there were choices being made directly about whether people were going to be admitted to critical care, which is different to whether people are admitted to non-invasive ventilation, CPAP, which is a different choice based on clinical evidence, but this suggests something different.
Yeah. May I just look briefly at one of the measures you took to try and make sure there was capacity, and it's the issue of field hospitals in Wales. I think you say in your statement that you were essentially responsible for ensuring there was the funding for the field hospitals and providing strategic oversight. Your words. Can I ask you, what strategy or strategic oversight did you provide?
So this is part of the planning assumptions, and so I will talk to Dr. Goodall about where we are, about the likely challenges we'll face, about reasonable worst case scenarios and what we need to provide for. And the field hospital network is part of doing that. And you'll see that the network shifted over time with the capacity in it. And, you know, to provide a field hospital, you need a building to do it in, and you need to have some staff to provide for it as well. And I think you've got to in front of you at the different model we had in Wales about step up, step down, and not suggesting we'd use field hospitals for extra intensive care, which I think was the right call. So I would then have to go and make a case to the Star Chamber for additional support. And I think in my statement I set out there was some pushback from the Star Chamber about the scope and the scale that was required. So I think that shows that scrutiny is real. And then the network is created. And then after the first wave, we then have a different and a smaller network of field hospitals available based on our experience going through the first wave as we're going into the second one.
Yeah. Obviously, you make the point that once they were built and funded, which was really you're responsible for getting the money in, if I can put it like that, the operational decisions about how they were used lay with the health boards. Is that correct?
Yes.
Can I ask, did you check as to how the field hospitals were being used?
Yes, I took an interest. So I knew that in the first wave, we'd only had, I think, 2 or 3 field hospitals being used. So then in the the discussion I had with Dr. Goodall about planning assumptions for what was coming next, taking account of the fact that we'd had field hospital capacity created that wasn't used, and then what would it look like? And that then shifted again as we go into the second wave and we then get vaccination available. So the mission of the field hospital building changed a bit, but in the second wave, we did see more people going through the step-down care in particular in field hospital we couldn't have done on the acute hospital sites that we had.
Given that it was a different model in Wales for step-down care, was any thought given to using them for non-COVID care or for the re-establishment, for example, of elective care, particularly in wave 2?
Yeah, I think the problem with that is that, you know, elective care often still requires a theatre. And, you know, if you require a theatre, I don't think the field hospital is a place to go. That's when you're really at, this is the only thing left to do before the whole system collapses. So the points about rehabilitation and about recovery, that sort of side of step-down care, they do make sense because otherwise you can't do anything. Some of your outpatient appointments could be used there as well. So the point around other parts of the system and how they can work, yes, but not, I think, when it comes to restarting elective lists.
Different topic, and that of PPE, please. Excuse me. You say in your statement that you were the lead minister responsible for PPE. Can I ask you this? Did you understand that FFP3 masks were more protective than the FRSM blue masks?
Yes, and I had to learn quite a lot of this really quickly because previously the minister I hadn't taken much of an interest in the difference between masks, but understanding the difference was quite important when it came to numbers and stock.
And when you came to learn it, when was that?
I can't give you a date, I'd be making that up. But actually, as we'd issued the pandemic stock that we had, so we had a pandemic reserve that was part of the UK arrangements, and actually we thought we had 6 months' supply. That's what the stock was supposed to be for. And of course, we went through that a great deal faster than 6 months. So the urgency of PPE was there throughout wave 1, and certainly by the end of March, early April, it was a growing concern because we could see that we were burning through our stocks in usage terms, and then all the points about what's appropriate, and people were fearful. So the recommendations on appropriate PPE to use, there was always an element of mistrust, and people are essentially bidding up for the next stage of PPE protection. So understanding the volumes of each item, how that related to the guidance and recommendation made about appropriate PPE and where and how you get it. And for me, and I've said this before, in April, this was a bigger issue for me than testing, because our understanding of the utility of testing at the time was different, and the capacity of testing at the time was different. But if you run out of PPE for your frontline staff, then you're in real trouble.
Number of things I want to ask you about that answer. Can I just ask you this? Who was it, or which institution was it, that led you to believe that FFP3 was more protective than the surgical mask?
Oh, it was the conversations I had both with Chief Medical Office, but also then just in the conversations about supply. So understanding why we have different grades of mask on the supply. So that would be both with Simon Dean and Alan Brace, who were Finance Director and Deputy Chief Exec of NHS Wales, respectively, but actually those don't really reflect what they were doing. Alan Brace undertook lots of the work with me on the stocks that we had and what they were for. And because he'd been in a health board before directly, he understood a great deal about the operation of the service, not just on a financial level, but the value he got from it. And so I had to pretty rapidly learn the different grades of equipment we had and what that meant for staff.
I think you say in your statement that at a national level, you did not run out of PPE. Is that correct?
That's correct. We had some very real challenges in distribution. So,
yeah, well, you say in your statement also there were initial localised challenges, and I wanted to know what does that actually really mean, Mr. Gething?
Remember, there were reports, and some of this came from trade unions as well as from some of the chairs and chief execs in health boards, about not being able to get PPE to frontline staff. They've been concerned and worried about PPE reaching them. And I think that I also saw a news report that suggested that in one part of the system at one point, people were wearing refuse liners because they couldn't get gowns. Now, that's not comfortable at any point in time, particularly when there's a pandemic running. And actually to then see on a national level, we think we have stocks. It's then about why isn't that stock getting to people on the front line? And so those are questions I don't just ask Dr. Goodall or Alan Brace. Those are questions then about, well, I need to know this is happening. And actually it came to not just about how the distribution worked. So part of the reason we used the joint service depots that local authorities ran was that you then had more localised depots of things as well. Because, of course, we ended up supplying social care too. So each of those areas where it appeared that stocks hadn't got to the front line was a concern for me because, again, you still get into inadequate PPE should not be what our staff are expected to deal with, even if we think we've got national stocks available. But if you run out nationally, then, you know, that really is into the scenario where, you know, you've got to have all the staff you need because you can't protect them.
All right. A number of things I'd like to ask you about that. Can I just take a step back to the pre-pandemic stockpile? I think you've told the inquiry in previous modules that PPE stockpile planning was incomplete and that the plan, as we know, was for a flu pandemic. And had you had a flu pandemic, you would have found it difficult. And, of course, extra so given that, in fact, it turned out to be a coronavirus pandemic. Dr. Goodall told us last week that the supply set aside was inadequate for a coronavirus. Would you agree with that?
Yes.
Can I understand from your perspective, did that mean you didn't have the right PPE or didn't have enough of the right PPE or both?
I think it was a bit of both. So I think I think I covered this in my statement where some of the eye protectors were just not fit for purpose. And so some of them had to be destroyed. Which is not at all comfortable, and that was from the pandemic stock. And it's also about understanding the different grades of protective equipment you've got and how quickly you're running through them as well. So I know there's a lot of focus on masks, but at one point we were worried about gloves as well.
I was exactly going to ask you about that, Mr. Gething. Can we have, to help you and those that are following, can we have up on screen, please, INQ 214235_21. This is a report from the Auditor General about the procuring and supplying of PPE that was done in April 2021, but it looked back to 2020. And I think the plan was for the stockpile and other supplies to last at least 15 weeks. Is that right?
Yep, even at the time we thought it would do, and
Yeah.
you can see here that it didn't.
Yeah, exactly. If we look at the gloves about which you were just speaking, you can see that the stock there was at the 1st of March. And from the week of the 9th of March, you had 1.5 weeks. It only lasted 1.5 weeks. That's
Yes.
probably the worst example on that page, but one can see there, again, nothing like the 15-week supply that you thought you would need to get through the initial stages of the pandemic. So clearly, going into the pandemic, there was an inadequacy in the stockpile, with which I think you agree.
Correct. Although actually, once we'd got on top of gloves, aprons were a bigger issue. But I spent lots of time worrying about this, and it did take up a significant portion of my time as a minister in wanting to understand where we were, where our supply lines were, and our relationships with other parts of the UK as well in purchasing this as well.
I think, in fact, you said aprons, but I think it was, in fact, gowns. Dr. Goodall said that you were down to about 2 days' supply of gowns across Wales. Putting aside the national position where you had enough, were you able to monitor what stock was held by each health board?
Not personally, because the figures I had, I looked at the run rate. I eventually had figures about overall stock supply, then at the run rate that they were being issued, and then actually it was for health boards and local authorities to make sure that the stock was distributed locally. If I tried to manage that or create a unit to manage that individually, I think we'd have stopped the system from working bluntly. But understanding the run rate that we had, so how much we're actually going through as opposed to what we thought we'd go through, how does that mean we need to procure, and are we getting that enough as well? I think the Audit Wales has lumped together aprons and gowns as opposed to seeing them separately. But understanding the types of items we needed, and with testing and with PPE, there were frankly an awful lot of shysters who were trying to make money out of inadequate equipment. The whole world wanted more, and some people saw that as an unscrupulous business opportunity, including inadequate equipment. So the systems we had weren't just about buy anything, it was about buy what we need of the stuff that can actually be used. And from the early weeks and the very real anxiety, we eventually got to a point where we were able to do that, but also the publication of stock, I think, helped with people's confidence about where we were. And that we were a bit upfront about it as well.
I didn't mean to interrupt you, Mr. Gething, but it may be that Her Ladyship's procurement module will look at those that sought to take advantage of the difficulties of which you spoke. But can I ask you about a difficulty that was brought to your attention? And could we have up on screen, please, INQ 299062_7. It's an email sent to you, Mr. Gething, from a consultant at a hospital on the 24th of March, so very early on in the pandemic. And the sender says, complete chaos at our hospital, no protection for nurses, very low, I think it should be morale, as being asked to care for patients admitted to orthopaedic wards by medics with respiratory symptoms, masks not being released. So a direct line into you there of some very real problems in that particular hospital. What did you do personally to follow up on this and ensure that the problems being spoken of in an email like that were in fact being resolved?
Well, I think the email trail that you have shows that I didn't just pass the message on and say, please deal with this. It was a conversation that I then had with our officials, with Dr. Good and others, about where are we, what's happening. And actually, as a minister, when you poke and prod in this and say, I want to know this, it does almost always deliver a response. So the work that we then had to do on, because often you just assume that PPE is available. As a minister, you don't normally say, I want to see all of this personally. Then understanding there is an issue both with how the system is being run, how staff feel, but with PPE as part of it, as a specific part of that. And I got not just interested, but I did something about it, as the email trail, I think, shows in the rest of the document. And it did lead to a greater structure being put in place, where I then had regular updates about PPE stock, how that was done, and it led to me making choices about publication. Not just this individual, but this was an issue that was raised consistently by trade unions in the first couple of months as well.
Yeah. Can you help? How often did you get an email like this, Mr. Gething, across your time as Minister?
Rarely.
Okay.
So, as I say, the system's small compared to England. So there are people, when you go around and visit, you meet them 2 or 3 times. So eventually they feel they can trust you and tell you things. But in the pandemic, I did not get a regular point of contact, emails from consultants, including those that I'd met, saying, this is the problem I have in my workplace, can you do something about it? It's part of the reason that I took it seriously was this was an unusual intervention from an area of the country that we expected there to be real concern, because the socioeconomic gradient we expected with COVID.
You mentioned there, I think, the TUC bringing issues to your attention. I think one of the things they say in their statement to the inquiry was that some workers had to resort to wearing bin bags or buying visors, goggles and hairbands on which to hook poorly fitted face masks. In some places, homemade PPE was donated to workers, the use of which was available sometimes increased their risk of infection, and in some cases led to workers being reprimanded. And, Mr. Gething, we also heard from Jonathan Rees, a pharmacist, who, amongst other things, told us that a local school's DT department started making masks and their own hand gel to provide it to the pharmacists. Were reports like that being brought to your attention throughout waves 1 and 2?
Yes, so in wave 1, not in wave 2.
Right.
So in wave 1, I'd seen a news report of bin bags being used, which really did concern me. And the email you've just brought up is from the start of, the start of lockdown, March 24th. We've just gone into lockdown. And so, yeah, that was part of the reason I took an extra interest. When we got into wave 2, actually, our procurement and delivery systems, I didn't get anything like the same concern at all. And we'd had regularised use of other parts of our system that were making products. So hand sanitizer is probably the easiest example, because lots of people made it. Lots of breweries and distilleries ended up making lots of hand gel. I still got hand gel items around the house from all the people that made enormous amounts of it, and the making of the visors as well. So lots of that happened, and we had a call out to the private sector to help us with it. We also had the Materials Authority, CERET, that looked at items to make sure they could be quality assured. So in wave 1, it was a real concern, particularly in the first half of wave 1. Then we had regularised and managed to get enough supply in, including mutual aid from other parts of the UK that we both received and contributed to. And then I think it was on a more even keel, but it was one of those things where people were always concerned, have I got the right PPE? And will I have access to it when I need it? And that's why the publication of the stock levels, that came from a conversation with trade unions. So the RCN, Unison, Unite, the GMB and the smaller unions, including the ones representing therapists, those conversations mattered because they did lead to the assurance that I think made a difference.
Given the concerns that were raised to you, whether it be by email, in conversations with TUC, with other stakeholders, do you accept that at times in wave 1, it appears that healthcare workers in Wales treated COVID-19 patients with inadequate PPE at potential risk to their own health?
I'm afraid that's possible, yes.
Finally, on PPE, were you aware of issues that FFP3 masks did not always fit women or did not suit people from a non-white ethnicity?
Yeah, so the problem about fit test was real, and that definitely did get raised. So it was part of the point about what was being procured, and actually about making sure the fit test process was done properly. So people of different size and shape heads. So were these masks essentially made for big blokes and not for women? What about men with beards as well? So there were real issues about fit tests for a number of workers because, you know, healthcare workers don't come in one simple shape or size. So the fit test process mattered. That also made a difference about wanting to make sure that we procured items that people could safely use.
Yeah. What did you actually do then to ensure there was a sufficient variety of FFP3 marks to fit BAME workers, to fit women, to fit people that had beards? What did you do, Minister?
So that came up in the conversations that I had with officials, not just about the stock, but as it became more of an issue about, look, there's an issue about how these masks fit everyone. So again, with the group of officials that I worked with and I had responsibility for, we did go through not just the concerns that were being raised, but about what was being done. So, you know, that assurance process did take place in direct conversations with the team and the work that shared services were doing on procurement as well. So it wasn't a simple shrug your shoulders, never mind. It was, well, what are we doing about it? And that's assurance I got from officials.
By the time you left your position, were you satisfied that there was a sufficient variety of types of FFP3 masks to fit a broader range of face sizes, shapes, ethnicities and the like?
That was my understanding, certainly. And actually, in the heat of the second wave, again, I don't recall there being conversations with me about the fact that there was a regular shortage or a shortage of the right type of mask. But I know that it was a regular point about having fit tests done, particularly when you had a new group of staff who needed to be redeployed into areas as well.
Can I leave PPE for a moment and ask about some other topics, perhaps before we take our mid-morning break? And can I ask you, please, about long COVID? It was known at the start of the pandemic that it was likely there would be long-term effects caused by the virus. Was that brought to your attention, even if they don't know the specific types of long-term consequences?
Yeah, so at the start, understanding that for most people it would be a mild and transient condition, but for a significant number of people, even if a small proportion, it would be much more serious, and the recovery was uncertain for some of them. Yes, and the challenge is always then about learning as you're going and not understanding what it's going to look like at the outset.
Can you remember when it was you became made aware that there was likely to be some long-term consequences, perhaps even not necessarily before it was named long COVID, but at least the acknowledgement that there would be a long-term...
I can't remember the exact date, but I do recall having conversations with the chief therapist and the conversation with her about rehab. Part of this was about the wider system. Part was also about how you help people with rehabilitation from COVID. So it wasn't called long COVID at the time. But if you understand there's something that affects your organs and actually how do you help people with that, that's definitely in the rehab space. So I had a conversation with the chief therapist advisor and she was one of the lead people on looking at what we should do to try to support people with what has become known commonly as long COVID, with the long-term consequences.
Now, in your statement, you say that in May 2020, you agreed a national framework for rehabilitation. Does it follow from what you've just said that your conversation with, for example, the chief therapist happened before that framework was brought into being?
Yes. Yes, so I definitely had a conversation with her about the work that was being done to deliver a framework before the framework was published. It isn't the way that you learn about those things on the day.
Now, in Wales, the approach was to support the rehabilitation of those who'd had COVID-19 but were still suffering from its after effects. It was decided that that should be delivered at local level through existing primary and community care services. Why was that decision taken in Wales?
Because that seemed the most sensible way to do so, given the way our system is organised and run, given the way that a Healthier Wales talks about how we want to run the system. So services that need to be highly specialist, where people need to travel for care, taking place, and other services being delivered as locally as possible. And actually, I think this really is a space that should be primary care led. rather than requiring people to travel to secondary care facilities. And it's then about making sure we have the staff to do it and the knowledge and the understanding to do it as well.
How did you ensure yourself that that level of care was being provided through primary and community care services?
So we have the framework we provide, and it's then about our understanding of what is taking place. And so, health boards have the responsibility to deliver on the strategic choices that are made. And I was aware that there were, as we went through the pandemic, there were ongoing conversations about long COVID and its treatment, and also about getting staff equipped to understand what long COVID was, because it was a new condition for them to see as well. And I know that caused some distress for people suffering with long COVID. But actually, how you get this is a regular part of care that is delivered as locally as possible. And I expect to be a standard part of the way that primary care still works today, because there are people with the condition today who will almost certainly get almost all of their care needs delivered in primary care.
That May framework, I think, was updated in October. And can I ask that we have a look at your paragraph 345, Mr. Gething, in your statement? It's 474252_130. It may be coming up on screen for you as well, Mr. Gething. There you are.
Yes.
Paragraph 345, you provided the update in October 2020. At that time, the longer-term impacts of COVID-19 were becoming clearer. In Wales, we did not have plans to develop rehabilitation centres as in England. It was anticipated that it would be a relatively small number overall of people recovering from COVID-19. So instead, our approach was focused on providing care and support as close to home as possible. Can I ask you about the line that says it was anticipated there would be a relatively small number overall of people recovering? On what was that based?
I can't recall who gave the advice, but that would have been the advice on the numbers of people who are having longer-term consequences, people who are still having challenged from COVID after 4 and 12 weeks. And think about the number of people that had COVID. I've had COVID twice, and it's a proportion as opposed to an overall number. And it is then about how you deliver the services people require. If we had 2 national centres in Wales, it would have been convenient for a small number of the population, and everyone else would have been inconvenienced. And equally, if it isn't part of primary care, then essentially you're managing up from primary care into 2 specialist centres. And I don't think that approach would have worked in Wales, and it would have been wholly contrary to the method that we'd set out in a healthier Wales itself.
I understand that, Mr. Gething. It's not about how you decided then to divide it up geographically, but what was the relatively small number upon which you were basing the decision about how to treat and care for people with long COVID? 1,000, 10%? What was the figure in mind?
I can't recall without looking at the statement and going back into the documents, and there's almost certainly ministerial advice around this as well.
It's just that long COVID data certainly wasn't being collected by the ONS until April 2021, and as at that stage, 56,000 people in Wales were have certainly self-reported as suffering from long COVID. Was that the relatively small number that was being envisaged in this paragraph?
I couldn't tell you, because without going through the documents, I'd be inventing an answer, and I'm very keen not to do that. From October 2020 to now, I think it's fair to say that we have, because we hadn't been through the second wave in particular as well, we have a larger number of people. It's a much more common condition of significant variance than we'd have anticipated in autumn 2020.
All right, well, let me ask you this. There may be some in this room even that think that because you thought it was going to be a small number, that's why long COVID clinics were not set up in Wales. Is that a fair comment to make or not from your perspective?
No, and I think if you look at the advice that I received at the time and acted on the statements I gave, it was actually what's the appropriate model of care to make sure that care is local, to make sure the care is easily accessible, and you help them do what they can do with and for themselves with support, and where they need intervention or support from a healthcare worker, that's available as well. So it's really about what you think the right model is, rather than wanting to underplay the importance of it.
No, all right. You've set out the rationale for a different approach in Wales, but evidence received by the inquiry suggests that the Welsh approach means that patients who are referred by primary care to specialised services now end up having to go and see a number of specialists, rather than, if you had the long COVID clinic model, it would be more of a one-stop shop. Did you appreciate that in setting it up in this way, there may be a need for those who have a very many long COVID symptoms to now have to go and speak to very many specialists?
Well, there's always a bit about how you learn from the different models that are available. And I know that Judith Paddick has given observance on this as well. I'm always interested in how we learn from the way we've got different delivery models and what that means in terms of outcomes and patient experience. I don't want to get drawn into trying to adjudicate on the right clinical model, because whoever the health secretary is in Wales will have to look at that clinical evidence and listen to patient experience. And I think you've got evidence before you in the inquiry about the engagement that did take place between medical officers and the chief therapist advisor and patient representatives living with long COVID as well.
Can you help? How, when you were as minister, were you provided with information about the numbers of people long COVID, if at all?
So it was both in the conversations that I had about the rehab framework, the focus on long COVID, the statement that I gave on long COVID in the October. And I think there was a further conversation that took place in the spring as we were going through, so spring 2021. So it was the engagement with, and from my perspective, the lead person that I spoke to was the chief therapist advisor, because lots of support people required was in the therapy space, but of course, there was, for some people, a medical need as well. That's the challenge of dealing with. It's not one condition, because it affects people differently. And so that's why you need to have a framework that takes account of different need.
Do you know whether there was any central reporting of the number of healthcare workers that were diagnosed with long COVID?
It's my understanding that we didn't have that. And so you have this challenge of wanting to understand what happens on a whole system, but you've then got to marry up someone's employment record with their individual patient record. You need people's permission to do that. I think it would be really helpful to understand the number of healthcare workers affected, but that does mean you've got to get permission from those people to gain access to that information on what basis.
Do you think that data should be collected by the health boards and then fed up to government, or it should be collated nationally?
Well, the starting challenge is you've got to agree a consistent way of asking healthcare workers if they've had long COVID, and then whether you want them to self-report or whether you want them to have access to their medical records to understand the interventions given. Employers, where there is an impact on that person's ability to work, should understand that. And so there may be an opportunity to do something on an anonymised basis, but I still think you'd need to agree that in partnership with trade union side, because there's always the risk that people fear that if you're looking at how my employment has been affected by a healthcare condition, that it's not always for a benign or positive purpose. I say that thinking back to my own time when I had a real job as a lawyer.
I remember it well. Let me ask you this, though. It's not so much about the difficulties in who's going to provide permission or not, but who do you say should be the body responsible for collecting the data? Putting all the difficulties with collecting it aside, who's going to do this, Mr. Gething?
Well, I think really health boards and trusts and employers are the ones that are best placed to collate the data, but that would almost certainly come from a national agreement involving the Welsh Government on what to do broadly about collecting data, but also why. So you're not just collecting data for the sake of it, but why and what do we want to understand? How does that help us? Understand the scale of the problem, understand what to do about it, understand practical approaches to supporting people long COVID, to keep them in the workforce, which I think would be largely the objective. So I think there would be value in doing that, but you need to ask yourself some of those questions first, otherwise you'll end up with potentially 7 different approaches.
Mr. Gething, that maybe takes us conveniently to our mid-morning break.
It is. I shall return at 5:30.
Thank you, my lady.
Ms. Carey.
Thank you, my lady. Mr. Gething, can you hear me all right?
I can hear you fine, thank you.
Good, thank you. Can I turn, please, to the issue of nosocomial infections and the testing of healthcare workers? And can I ask you this? At your paragraph 295, you set out that at the start of the pandemic, on the 21st of March of 2020, Wales set an ambition of 6,000 tests a day by the 1st of April, 8,000 a week later by the 7th of April, and 9,000 by the end of April. And can I ask you, was that a target ambition to cover tests for patients and healthcare workers?
Yeah, it was to use the tests in accordance with what we thought the value of testing was at that point in time. So, symptomatic patients
Right.
and workers, yes.
Thank you. Were any of those targets met?
No. And I think I explained that in the following paragraph about the unfortunate business with Roche and
Yep.
the way they engage with us, Wales and England.
Yes, you do. It's set out at your paragraph 296, Mr. Gething. But I think, in fact, by mid-April, 20th of April, the 9,000 testing target for the end of that month was abandoned as well. Do you know how far short Wales had fallen as at the 1st of April, 7th of April and the end of April?
Well, apart from the 5,000 that we thought we'd get, I think we also had some issues with supply chain, because I'm not sure if this is in my statement or in others, but equipment that had been pre-ordered by Public Health Wales hadn't always arrived, and we also had issues with some of the reagents as well. So I think without the 5,000, I don't think we were far short, but I haven't got that in front of me.
All right, so you don't know what the position was at the 1st of April, whether you had 1,000, 1,500, 2,000, what you had by 7th of April or what you had by the end of April?
I can't tell you offhand, but there will be figures available about the amount of testing that we had and how it was deployed.
I ask about testing because clearly it has an impact or an effect on nosocomial transmission and how one tries to prevent acquiring hospital-acquired infection. In Wales, is this right, that the nosocomial transmission group was established on the 19th of May of 2020, and you say in your statement that was a group that did not report to ministers. Why did that group not report to ministers?
The group didn't formally report to ministers in the chain, as it were, because the chairs and co-chairs, that the deputy chief medical officer and the chief nurse, were part of a senior group of officials, and so actually our understanding of what was happening at the time, I had reports both from Chief Scientific Advisor on Health, the TAC and TAG group, Chief Medical Advisor, and the Chief Exec directly to me. So nosocomial transmission was a real concern that was regularly discussed with me, and it was one of the Chief Medical Officer's concerns about the estate that we had, and about the fact that it didn't make for good infection prevention and control.
There was evidence, I think, of nosocomial transmission, certainly in one of the health boards from as far back as March 2020. Can you help with why it was that the group wasn't set up then until the 19th of May 2020?
So nosocomial transmission is a regular feature of healthcare work, and the fact that people can get additional conditions whilst they're undertaking healthcare for something different. And so given that we knew it was an infectious disease, an infectious condition, I understood there would be some nosocomial infection. And the evidence about what was taking place in March wasn't really revealed until later. I think there's a document in evidence about a study that showed that there was a cluster in an iron bevan that appeared to be driven by nosocomial transmission. But the challenge is how you get people to adhere to good IPC practice, how you have PPE to help with that, and then how the estate helps or hinders with that as well.
I understand that. In fact, it was Public Health Wales that produced a report on the 31st of March, which certainly showed there were outbreaks in an iron bevan, I think, that was consistent with nosocomial transmission. It's not the fact that everyone acknowledges there may be nosocomial transmission. The question is why it took so long to set up the group, given that it is obvious to all there will be at least some healthcare-acquired infection.
Because this is part of how a health service operates, and there should be a focus on good IPC practice as a regular part of healthcare. So pre-pandemic, it was one of the things that I spoke to chairs and others about the levels of healthcare-acquired infection that took place. And so there is something it's about practice, it's about how rigorous that is, and, you know, not just if you're the minister going on a visit about making sure you roll your sleeves and tuck your tie in, but actually what happens as a matter of course. So you don't see, you know, old pictures of, you know, consultants with long sleeves and a tie wandering around leaning over people. Actually, all those things matter. The group was there to give a focus to what was happening and to try to draw together what was taking place nationally. So it was a response to what was taking place in front of us.
All right, I suppose the question is do you think that response was too slow, given that you knew at the end of the March that it was happening, that it inevitably always happens? Why not set up the group sooner?
Well, because the expectation is that this is what happens normally. And you should have, as in normally, you should have people getting on top of nosocomial transmission. And when you see it isn't, it's then what you do about it. There's the normal line management, whether that's the CMO or DCMO talking to medical directors and the chief nurse talking to nurse directors. And then actually, as that didn't deliver, this group is set up. I think it's fair to ask a question about how soon is it set up in a future pandemic? How soon do you actually reiterate the need for fairly rigorous adherence to good IPC practice and the fact that there are consequences for healthcare workers and patients if you don't? So look, I'm perfectly prepared to accept that even in the moment and at the time, could we have acted earlier? Quite possibly. For the future, it is one of the things I think it is worth doing about saying, make sure if you have an infectious disease in a pandemic, that nosocomial transmission is an early priority with a rigorous reinforcement of why good IPC practice is essential.
All right, can we have a look at some of the figures, please? And can I ask that be put on screen INQ 396261. This is, in fact, a briefing, I think, provided by the Nosocomial Transmission Group on the 15th of November of 2020, and it sets out not just hospitals but care homes, but I'm obviously just going to focus for today's purposes on hospitals. As at November 2020, rates there are increasing as community transmission has increased. We can see there during the last week until the 8th of November, there were 210 cases of probable or definite hospital-acquired COVID, which represents 3% of all cases diagnosed, but 50% of all cases diagnosed in hospitals. And then set out per board the number of cases and the percentages. We can see there from TAF with the highest number, followed by Swansea Bay.
Mm-hmm.
And indeed, if one goes down the page a little bit, reference to Public Health Wales data indicating how many patients were COVID positive in hospitals, how many beds were occupied by people who didn't have COVID. Around 3.5% are being infected each week by COVID within the hospital environment. That's presumably across the whole of Wales. And I think it's this. Evidence suggests that properly used, I think it should be PPE, limits transmission between staff and patients, but transmission is occurring. Transmission between staff is often seen as a result of a lack of social distancing in non-clinical areas. Although staff should test positive at a similar rate to their local community, one health board found 24% of staff were positive, despite an approximate 1% of community prevalence. When you received this briefing, what steps, if any, did you take to try and ensure that IPC measures were being properly enforced, that there was properly used PPE, that you were limiting insofar as you were able, Mr. Gething, to ensure there was social distancing in non-clinical areas?
So I can't recall definitively what I did in response to this particular briefing. But I do recall that about this time is when we were going through further iterations of what we were doing with testing around outbreaks, whether they were care homes or hospitals. And we knew that we had outbreaks around hospitals where we'd undertaken wider testing. And the testing infrastructure was becoming more portable, because this is just on the cusp of lateral flow devices. So I think we'd use lateral flow devices around potential outbreaks as well. So this was around, again, the reiteration of why it's important. And I think the transition between staff and the lack of social distancing in non-clinical areas, that's really difficult because, and I wouldn't want this to be seen as a staff not being interested about this, but actually it's the pressure they're under, and it's what happens when they feel a sense of relief at not being in a clinical area. It's a fairly human response, but there are consequences, and that's why the rigour in not doing this really matters. So I recall having conversations with the DCMO and the chief nurse about nosocomial transmission, about reports they were bringing back from this group and what they were looking to do to try to make sure that our whole system responded. I can't recall for you whether I had a conversation directly about this with chairs, but I know that chairs of health boards raised it themselves about things that they were concerned about throughout the pandemic.
May I ask you this? A number of times this morning you've spoken about the conversations you were having, and you've told us about how it's a smaller community in Wales and so perhaps doesn't have the formality that one might otherwise expect. But how are these conversations recorded so people know what it is you've told them that you want done?
So if I'm having a meeting with the chief nurse, there will be a brief minute. There'll be a minute of the meeting. It won't capture chapter and verse about what's being done. There are minutes taken of meetings with chairs of health boards. There are the conversations with trade unions are more about us agreeing action points at the end of that, rather than there being an exhaustive minute of it. So, in the significant number of documents, there should be documents that point out when those conversations are taking place, not just the briefings delivered, but also you should be able to see practice from those service leaders about what they're asking the service to do. And the fact that this data wasn't kept secret in that sense, health boards knew they had problems. And in fact, the way that Test, Trace, Protect was deploying testing resources around outbreaks, again, every time was reiterating, there is a reason why this is happening. Protect yourself and the people you care for when it comes to the service. But this is very, very uncomfortable in the pandemic and now about understanding that infections on our hospital estate were a real factor in the harm that was caused.
I think you have seen that there was a second briefing by the Nosocomial Transmission Group in February 2021, which showed a position that had worsened from the November 2020 with effectively higher rates of nosocomial infection. Did you put into place any steps between wave 1 and wave 2 to try and reduce the amount of nosocomial transmission? And if so, what were they?
I can't give you a documentary review now about pointing to a particular document. But I am clear that the Nosocomial Transmission Group directly impacted on conversations with chief execs and chairs about what was happening. And I'm pretty sure it's part of the operating framework as well, about how people were supposed to be dealing with where we were. And it's not a surprise to me that transmission increased as by the time we got to February, because we then had a more transmissible variant in circulation across the great majority of Wales. So even if there'd been an improvement in practice, actually, COVID was even better at spreading.
Yes, everyone understands that variant was more transmissible, but that might be seen by some to be an easy excuse to explain away what, on one view, is a worsening position from what was already bad in November 2020 to incredibly bad by February 2021. Was there anything done to try and establish whether it was the sheer transmissibility or whether IPC had improved or worsened? Do you see the point I'm making?
Yeah, and so my understanding is that the Nosocomial Transmission Group and its direct engagement with the service and the leadership around that is what should have made the difference. And in particular, nurse directors have a lead role on IPC in their health boards around the practice and the culture developed around it. The challenge is, when you recognise something's gone wrong, how you then get back to it. And I know that it is, again, one of the points I think of learning for the future about the importance of IPC, because there's no sugarcoating the fact that the position worsened and real harm was caused. So I'm not trying to avoid that. It's an explanation rather than an excuse.
Slightly different topic but related. Did you consider or receive any information about the impact of nosocomial transmission on patients who were clinically more vulnerable, given that those who are clinically vulnerable are more likely to need to go into healthcare settings to receive their ongoing treatment? Was that brought to your attention at all, Mr. Gething?
I don't think I had a specific report about nosocomial transmission and the clinically vulnerable. But I always understood that people with greater comorbidities that we saw in our hospital estate in the second wave in particular, in even larger numbers, and the fact the hospitals was fuller at the start of it, because we'd restarted some activity, meant that there was a greater potential for harm.
In March 2021, there was a framework for COVID testing of patients in hospitals in Wales. Do you think that framework was published too late, given the rates of nosocomial infection that we've just looked at?
Well, by that point, we'd been testing patients on entry into hospitals and during their time in hospital as well. So the framework draws together both the updated evidence, but also practice that has already been taking place. And that was important both for entry as well as treatment, as well as discharge. Discharge had been a real issue throughout the pandemic, and having the confidence that people no longer had COVID or were no longer infectious before they could be moved. So the framework in March drew together practice that had already been taking place, as opposed to an entirely novel approach where no testing had been taking place before then.
You've mentioned a number of times the hospital estate in Wales. Did you receive any requests for funding to increase ventilation, particularly, for example, HEPA filters or other portable ventilation, to try and assist with that aspect of IPC?
I can't recall if I did or if I cleared ministerial advices on that basis, but I do know that health boards did manage to install additional ventilation. Again, I know that in Phil Clare's evidence, he pointed out that in Glangwili, you couldn't open windows all the way open, and there's a good reason for that, but they did manage to acquire additional mechanical ventilation to help with that.
Given that you lived through it as Minister, do you consider there is a need for more steps to improve ventilation within the NHS Wales estate as a mitigation against future pandemics?
Yes, but the starting point is what does the estate look like now and what will it look like in the future? Because actually, it would be a better answer to have a new premises as the main DGH for West Wales, rather than retrofitting onto old buildings. But if you can't deliver that entirely new estate, then of course you need to take the steps and the measures that you can do.
DGH, District General Hospital, is that what you meant?
All right.
Okay. Finally, this please on nosocomial. Were there any investigations set up in your time to investigate cluster outbreaks in hospitals?
Yes. So I recall, for example, an outbreak in Wrexham where there was an investigation about why it had happened and how, as well as the testing for a wider group of staff as well. So And that approach was being taken where outbreaks took place. But the Wrexham example is one that sticks in my mind.
May I, in the few minutes that I have left with you, Mr. Gething, go through a number of discrete topics, and the fact I'm dealing with it quickly should not be taken to diminish its importance. There may be other questions that you are asked about it around the room. Can I start with shielding? In Wales, we know that obviously shielding was brought in March 2020 until at least the 15th of June. But in fact, you did not pause it, I think, on the 31st of July, as other countries did, but extended it to the 16th of August 2020. Is that correct?
Well, actually, we maintained
Excuse me.
the time that we'd already announced. If we'd ended it on the 31st of July, we'd have had to bring the end of shielding forward. We'd already told people we'd shield till that point in August, and I've set that out in my evidence.
All right. I think you said you didn't pause it earlier, but extended it to 16th of August to give, in part, people time to prepare as a result of concerns raised by the Disability Equality Forum, and because you were concerned that people felt, to use your words, abandoned, not liberated.
People were fearful, and if we told them everything's fine, go out and about, but be careful, I think we'd have had a real challenge if we'd have said we're ending shielding early, because that would have been the message. And again, looking in hindsight, I think how you manage an intervention like shielding, how you tell people you are particularly vulnerable to take extra care, and then how you bring people out of shielding is actually really difficult in terms of managing human behaviour. Because, you know, at that point I thought the summer was going to be as good as it was going to get for a while. Didn't quite anticipate the speed of the second wave in the autumn into the winter. But again, it's one of those decisions where there is harm, whichever way you look at it, as well as potential benefit.
How were the concerns about feeling abandoned and liberated, people being worried about how disability groups would be able to manage the transition? How were they raised with you, Mr. Gething? Through what fora?
So there was a direct conversation with Jane Hutt, who was a Deputy Minister dealing with the sector at the time. I think the Chief Medical Officer attended as well. I then had those conversations, direct reports back around how people felt. And so I looked at what the feedback we were getting and how you help people to feel that they're being supported. That's both with the volunteers who were in place by then. The food boxes weren't just, I think, eventually about having a supplier, but it's also contact with other people. And I had to go and see my own mother. And so actually me delivering her shopping meant she saw someone. And, you know, regularly having to tell her, I can't come in, I can't give you a hug, was difficult, but I actually got to talk to her. And so part of that was about the contact people had, and the connection, and at the same time, not wanting to feel that people are going to be made vulnerable if they have too much contact with other people. If my mother had got COVID, it would almost certainly have been from me, because for a substantial period of time, as well as my duties, I was the only person who was going to visit.
May I ask you about data? And in particular, can I ask you about ethnicity data in Wales? I think you know from the work of the subgroup of the BAME COVID-19 advisory group that there was a disproportionate impact on minority ethnic communities. And could we have up on screen, please, INQ 227599_2? It's the front page, Mr. Gething, of a report from the BAME COVID-19 socioeconomic subgroup from June 2020. And if we could just look at the racial inequalities section. The report finds that race inequalities exist in Wales. In light of COVID-19, the lack of or poor quality of ethnicity data has resulted in poor health decisions, and BAME communities face a higher risk of catching and dying from the disease. Also captured are the experiences of racism from specific BAME groups exacerbated by COVID-19. Do you agree that going into the pandemic there was a lack of or poor quality of ethnicity data?
Yes, so the data field weren't always completed or pursued. we understood generally what our health service workforce looked like, with a higher degree of black and brown people within it than the wider population, and actually people within our communities. None of what this part of the report says was a surprise to me at all.
With that in mind, why was the data, though, if it's not surprising, why was the data so poor? Why haven't you and other ministers done something to improve the quality of the data?
Well, the quality of the data requires you to invest in it, and it requires there to be a response. We get staff alongside understanding why the data matters and what it's going to do. So we set out a series of responses. I think I've covered these at some detail in my statement about what we were doing to try to improve the data. And it's also why the risk tool that was developed reflected the fact that ethnicity was a factor in the level of your risk as well. Trying to capture those different fields of data isn't just about a celebration of diversity in the service. It's practical as well, and that's why in response to this we finally had some a practical shift behind. There's a real practical reason to do this in amongst all the other priorities that the service has to deliver.
All right. Can I go on in this document to page 8, please? Because the recommendation of the subgroup was this: to take immediate action to improve the quality of recording ethnicity data in the NHS and across health and social care services, to ensure parity of BAME data collection, monitoring and reporting. What immediate action did you take as Minister, Mr Gething?
So this was part of the response I set out in my statement in paragraph 164. I go through in some detail about not just what's happening in the NHS, but across the government. So there is more data that's been collected. There are still gaps, and there are further steps that are being taken to understand how we improve that data on the workforce. So it's not as simple as you flick a switch and then 2 weeks later all the data exists. And frankly, if we tried to do that in the middle of the pandemic, I think we would have got a pretty robust response. But it is about understanding and improving the data we have for a purpose. And like I said, that purpose is not just borne out in this, but it's about who you recruit, who you retain, where they are in the service. Some of that I'm aware of from before my time in public life, as well as the reality of where we still are now. So we're in a better place than we are at the time the report's published, but there's a good deal further to go.
Do you think that the paucity or lack of the data available to you for ethnicity affected any of the decisions that you took whilst you were Minister, or had there been better data you might have taken a different decision?
I think once the data became aware that different ethnic groups had a higher risk to harm from COVID, if we knew that earlier, then we might have made other choices. When we had the risk tool, it was helpful. It provoked individual conversations about what took place. So some of this was about ethnicity data, but some of it also was about occupational segregation as well. So the fact that being a taxi driver or a bus driver meant you had a higher likelihood of getting COVID than being a teacher was evident from the data, but also some of that also overlaid with the ethnicity data as well. So it's about the wider population in addition to what we're doing in the service. But I couldn't point to an individual example that if we had better data in February 2020, that we'd made different choices, because actually the learning on the differential impact for ethnic groups came during the first wave, not before it.
In relation to different data, was any department or organisation that you are aware of monitoring the deaths of healthcare workers from COVID in Wales?
I saw figures on deaths of healthcare workers at various points in time. So employing organisations were aware, of course, and they reported those deaths. And I can't remember if it's Public Health Wales, it was through health boards and trusts themselves. But yes, I was aware that healthcare workers lost their lives, and I was aware of the impact that had. I know sometimes large organisations can seem remote, But in my dealings with chairs, I can tell you they really were affected when members of staff lost their lives.
A different effect on healthcare workers. You've told us about how the views of the front line via your conversations with the BMA, the Royal Colleges alike were helpful to you. I think you are aware that there was a nursing survey done in November 2020 where 34% of staff felt undervalued by the Welsh Government, which was the highest percentage of across the UK, and that 74% had seen increase in stress levels. When you were made aware of the feelings of undervalued by the nurses, what steps did you take to try and mitigate or make less bad, I should say, the undervaluing that they were feeling?
So I discussed the report with the chief nurse. I'd be caught off guard by the report because for all of the regular conversations we had, I learned about this survey when the press release came out. And so actually then understanding what you do to try to understand why people feel less valued from the headline figure was actually, I placed enormous store on what our staff were doing. So from my own position, I'd always valued our staff because you can't run the service without them. And I'd valued that because of my own interaction as a patient. So it's how you get over and understand that people feel bruised and not recognised. Sometimes that's through pay and reward. A lot of the time it's through what you say as well. But I know that the chief nurse had conversations with all the nursing directors, and it came up again when I had those conversations with trade union groups as well.
I've got 3 short topics I must cover. DNACPRs, Mr. Gething. At any stage of the pandemic, whilst you were Minister, were you made aware of concerns about blanket or inappropriate DNACPRs being imposed? And if so, what did you do in response to those concerns being raised?
Yes, so the Older Persons Commissioner raised general concerns about DNACPRs. She didn't give me any specific examples, but we did have certainly an instance where a practice had written to people, I think suggesting there'd be DNA CPRs, and that just wasn't appropriate or in line with policy. So we dealt with that, not just with the practice and the board, but we did then reissue the guidance and make clear the guidance that had come through the ethical advisory group. And I think the CMO and the CNO wrote out to health boards, medical directors and nurses. But part of the challenge is in how you get over to people. The pandemic doesn't change DNA CPRs. There should be an individual conversation about that with the person, with their family, about what this means. And it was never appropriate to have a blanket policy. And I know some disability groups were concerned as well. So I think we reissued and reiterated guidance on several occasions. And I certainly publicly dealt with the issue with the general practice that was brought to my attention.
Visiting restrictions, please. In your statement, you set out that you were very sympathetic to those affected by visiting restrictions, particularly within the maternity setting. Looking back now, Mr. Gething, do you consider that the visiting restrictions struck the right balance between the benefits of visits to patients and their families and the reducing the risk of visits bringing in infection?
In hindsight, I think that we might have done more to enable visits. In the maternity field, having whoever your birth partner is, whether it's the other half of the woman giving birth or not, I think the support for the woman giving birth, but also, and I think about this because I think about my own life and becoming a parent, and if I'd been a new parent in the pandemic and not able to go to the scans, you can't get that back. And so there's the challenge of how you then have enough safeguards in place to make sure that you're doing all those things in a way that matters. And in particular, people with cognitive impairments and visiting is a part of how you keep that person well. So our ability to scale up testing to make that safe, but to appreciate the harm being done if people can't go there, and to balance that with the very real fear that staff had about additional transmission. So there is always a balance to be struck, but I think the chief nurse at the time has reflected on this, and I think it's definitely a learning point for the future about how you strike that balance and how you explain it, and then how you review the evidence over the different harms that are being done in practice.
All right, you said there, in hindsight, we could have done more. Can you think of a practical suggestion of what more could be done, absent testing being available?
Well, you could have used PPE as control measures, but you're still dealing with risk, and it's the balance of risk as opposed to saying there was no risk. Having, in particular, if a couple live together and one part of that couple goes in for the scan, there's a fair argument about whether actually you're reducing the risk significantly by only having that person in, whether they've got direct contact with the person they live with. So I think there is something about that, whether it's a scan or whether it's the ability to go into a neonatal ward if babies are particularly ill. So I think there is something about understanding and seeing them as a unit in the way that we did later in the pandemic, see households as a unit. And so if you see it in those terms, then actually is the risk being increased to an unacceptable level if both of those people come for scans? And I think that's a good example of where you could say the balance should be in favour of both those people attending, whether it's neonatal care or scans or actually giving birth.
Well, it means you need to have more PPE in your stockpile going into a pandemic, doesn't it?
It certainly would, and that is a separate learning lesson for a whole host of reasons, and this is one of them.
All right. Final discrete topic is this. I think you've been provided with a copy of the Locked Out Liberating Disabled People's Rights and Lives report, which, although published in July 2021, looked back over your time as Minister. And in that report, disabled people certainly reported that their access to going to medical treatment and health services was severely disrupted. And lots of disabled people reported they were either in receipt of care or awaiting care and felt their health had worsened. During your time as Minister, was any specific work done by you or the department to ensure disabled people could access healthcare?
Yeah, I think the challenge is that disabled people covers a wide range of people. People with a learning disability, people with a physical disability, and many of those are, core participants, patients in the service. And so actually that group were affected, as was the whole population. I think the challenge is our understanding about, for example, how you make sure people are still listened to about their care, how they access that care when lots of it went to remote service, either telephone or on screen, but the fact that people still had capacity to make choices as well. So I understood why people were concerned about that, and the regular reports we had from both the Older Persons Commissioner, the Human Rights Commissioner, and indeed the disability equality groups that we engage with as well. So there are a range of things we tried to improve as we went through the pandemic, but I think the looking back is quite important to learn from what you think you've got right and not, and how that affects current and future practice.
Brings me on to my final question, please, Mr. Gething. If you could make one recommendation to Her Ladyship for how to improve the healthcare system's response in Wales, beyond having more tests available at the beginning and more PPE in your stockpile, what would the recommendation to Her Ladyship be?
I think you'd also have to just take out finance, because if you want to improve your housing, your estate, you've got to spend lots of money on it. I actually think that I've covered this lots in evidence, but I think a lot of it is how you make sure your system is as collaborative and as open as possible, so you can listen to the real experience of staff. And the challenge is always how you manage that. You can't say to tens of thousands of staff, ring the minister up, but it is around the culture in the service, and I think really matters, because you're asking staff to put themselves in harm's way. And so how you listen to them and value them, I think, really does matter.
Mr. Gething, they are all the questions I asked, but I think we're now going to turn to some questions from the core participants.
Mr. Weatherby.
Good afternoon, Mr. Gething. Can you see and hear me?
I can indeed.
I'm asking you a short number of questions on behalf of COVID Bereaved Families for Justice UK, which includes quite a number of families from Wales. And the two topics I'm going to ask you about have been dealt with to some degree by Ms. Carey already, so that'll allow me to go very quickly. First of all, shielding. Ms. Carey was asking you about the position of shielding in the middle of 2020. And you deal with this in your statement to paragraph 138. And you were explaining that although shielding was paused elsewhere at the 31st of July, you continued it in Wales until mid-August, and you gave us the reasons why. And that was that you'd been approached by the Disability Equality Forum, and there had been concerns about the abrupt stopping of shielding would leave people feeling abandoned. That's right, isn't it?
Right.
The question I have is that you note in your statement that the ending of shielding elsewhere in the UK on the 31st of July and the position in Wales may have caused confusion. Just this, did you raise this with the UK government or other devolved administrations and the concerns that you in Wales had about the abrupt stopping of shielding and why you weren't? Did you try to come to an arrangement which would have persuaded the other, the UK government in particular, to see the point of view that you'd accepted?
Well, the problem is that this was an example of where a decision is made and then announced, or essentially given to involved governments. And you either decide that there's more benefit in doing the same, or you say, actually, I can't and I won't do that. If I decided to go ahead with pausing shielding essentially 2 weeks earlier than had already been communicated, without having a conversation with my own stakeholders in Wales, I think that would have led to a lack of trust. So there's more than one thing. The decision isn't just a shielding choice in itself. It's more than that. And, I've expressed before some frustration about the way that some UK government choices for England were made without there being a prior discussion with all four nations.
Yeah, but that was my question. Did you actually have those discussions with the UK government, or were you just frustrated that they hadn't come to you first?
Well, I was frustrated, and it was certainly part of the health minister's call, but once the UK government decided to do that, they never changed their mind once they'd announced something. If a devolved government said, we don't think that's the right thing to do.
Yes, thank you. Okay, second and final topic, PPE, and again, Ms. Carey's certainly touched on this. Ms. Carey put to you the hospital consultant's email from the 24th of March, the chaos email, where the consultant was raising with you the lack of protection and lack of masks in particular for nurses. And then paragraph 317 of your statement, you assert that on the 21st of April, you publicly noted that Wales only had enough left in the stockpile for a few days. And you also indicate that there was an underestimation of how quickly PPE would be used, how rapidly supply chains would fail, and that some of the existing stockpile was not fit for purpose. Looking back on it, given what you said earlier this morning about what we saw on our screens from Italy in February, do you think this is something that you should have seen coming and you should have addressed the lack of PPE and the distribution issues you've touched upon? Do you think you should have seen this coming before it was raised by the consultant and before the shortage actually became apparent on the 21st of April?
I think there's a number of different things. The first is that actually, even with the example of Northern Italy, we still thought that we had a pandemic that would last for longer than it did. And until we were genuinely having to deal with it directly, it was hard to see that stock wouldn't last as long as it did, or indeed that supply lines would collapse in the way that they did. By the time we got to March, It was then the contracts simply weren't being fulfilled, and that gave us a real problem. And with respect, I don't see how we could, at that time, have anticipated all of that. But the second point, I think, is that by the time I made the statement in April, I'd seen what was happening. I was able to indicate we'd come within days of running out of some of the items, but we'd also managed to get mutual aid and more stock in. I was getting over that PPE was a real resource that had to be properly used to protect people, and it was something that the Welsh Government was taking a significant amount of interest in.
But following the what you saw on your screens in February, did you actually take any measures in between February and April when you made this announcement in terms of ramping up PPE or checking the PPE you had or checking the distribution measures that you had in place?
Yes, and I think I've been through this with Ms. Kerr, and it's in my statement. So I'd had conversations with the senior officials that I work with about the amount of PPE that we had, the run rate we had on that, where our new supplies were coming. There's, an infamous incident of tracking a plane that came in and landed in Cardiff Airport, and I think there were supplies from China and Cambodia that we got that were essential to us getting PPE. The failure of a flight in Turkey that the UK government said had procured. And actually, how we managed was a real concern and a real part of my activity as the minister, as well as making sure that we got stuff that was usable.
Yeah,
so it was a significant part of my time, energy and effort.
But that was going forward, presumably, from April rather than prior to April, those measures that you just talked about.
No, so I think it comes from the conversation, not just from the email on the 24th of March.
Yeah.
But actually, it's a growing concern and something that takes up my time through the end of March and April. It isn't just at the end of April that I suddenly get interested in PPE. I take an interest in it because of the reality of how serious an issue it was.
Final point. In Wales, the procurement of PPE was a dual approach where you had the Four Nations basis where the UK acted as the lead purchaser, and you had a Wales-based NHS Share Services partnership, I think.
Correct.
How did you ensure, as Minister, that those two parallel systems worked together, given what you said about the relationship with the UK government?
So PPE was a significant part of our conversations as ministers across Four Nations about where it was and, frankly, about whether there was enough trust that if the UK government was procuring on behalf of the UK, that fair shares would be properly delivered. I don't think the UK government's procurement mission stood up as well as the one that we were responsible for. Others will have their views, but we eventually managed to not just secure supply lines, but we provided mutual aid to other parts of the UK in more significant number. And it mattered because we had to procure not just for the health service, but also for social care. And at the early stages, not everyone in local government trusted the NHS to get that in because so many local supply lines were collapsing. So it was not a straightforward or an easy conversation to have either in Wales or with other parts of the UK, but we eventually reached a position where there was enough trust between different governments and crucial enough supply.
Thank you very much. Those are my questions.
Thank you, Mr.
Thank you.
Mr. Wagner.
Thank you. Good afternoon, Mr. Gething. My name is Adam Wagner, and I ask questions on behalf of clinically vulnerable families. I want to ask you a few questions all about the pause in shielding and shielding generally. And picking up on the questions that Mr. Weatherby asked you about the decision that you took to pause the pause, if I can put it like that, from the end of July to the 16th of August. Would you agree that at that time, so in mid-August 2020, there were no vaccines yet, so many of the most vulnerable people remained intensely vulnerable?
Yes. If they got COVID, they would have been, yes.
Yeah, and would you also agree that it was around this time that children were going to be going back to school, which would itself increase the risks of the virus spreading and potentially coming back into vulnerable people's households?
Well, yes, children going back to school at the start of September was one of the risk factors. It's also worth reflecting, I think, Mr. Wagner, that in the middle of August to the end of August, COVID rates were at their lowest. And so the risk at that point in time, and whether it justified continuing with shielding, and if you're going to give people confidence to do a bit more, then actually having really low prevalence rates is a time to do that.
Oh yeah, and I'm not going to ask you about the decision itself, but just looking at the risk factors, do you also agree that at the end of shielding would mean that shielding people would no longer be eligible for statutory sick pay when shielding, which would mean they potentially would be forced to return to the workplace?
The end of statutory sick pay, yes, that was a factor we weren't in control of because that's a UK construct. But also it would mean that you'd still have to then consider the individual points about risk assessment for workers in the workplace as well.
And overall, were those all factors that you were taking into account in that decision to pause the pause?
Yeah, it's a rounded choice. It's not a single factor, but it is the shielded population. Some of them are at work and still working from home. Some of them are not able to work at all because of the nature of their jobs. Some of them are worried. Some of them are just keen to get out and about. So I'll give you an example. I, on a brief family holiday I took, we met someone who sold us an ice cream, and she was saying how well she felt looked after, but she also said that she was shielded but decided she wanted to go to work. So it wasn't a requirement. It was an offer of support and the advice about the risk. People still have to make their own choices.
And just thinking about those risk factors, did you take or ask anybody in the government to take any particular steps to address those particular concerns, or to consider what mitigations could be put in place to ease the process of ending shielding? So, for example, psychological assistance or assistance with reasonable adjustments in the workplace?
So it was part of the communication about the advice on what to do now shielding is being paused. So they'd all had a letter from the CMO, and it was the right choice. I think it was a letter to come from the CMO, not from me, about why shielding is being paused, what this means, where they can continue to get advice and support. The Welsh Government can't do everything in the workplace about reasonable adjustments, for example, because that's an employment construct we're not responsible for legally, but actually in services we are responsible for, then yes, that was already taking place with what we'd asked employers to do, and indeed engagement with the private sector wouldn't have been done by me, but the Economy Minister, about asking employers to think about how they deal with the shielded population. So we couldn't give a directive, but there were regular conversations with employer groups around what we would want them to do. And we had a couple of instances where we thought there were problems in practice. But that was soft power rather than a hard choice, if you like, Mr. Buckley.
Thank you. And just finally, as you decided to pause shielding and moved away from this approach of guiding people and providing support for them to stay at home, did you consider moving away from that approach towards providing more particular information which could assist clinically extremely vulnerable and clinically vulnerable people in assessing and mitigating their own risks? So, for example, giving them more detailed evidence about the virus and the kinds of things they could do to avoid the virus, like masks, ventilation, those sorts of things.
That evidence was made available. So not to look at the CMO's letter directly advising people on steps and measures, but when engaging with health services or advice on how to minimise your risk for patients in particular. So there was advice, and the challenges at the time, you couldn't move without hearing about COVID. And on the clinically extremely vulnerable people that I met, they took very seriously the risks they had and the choices they made. If there is evidence that people didn't know, I'd be interested in how we learn from it.
Thank you. Those are my questions.
Thank you, Mr. Ward. Ms. Waddow.
Good afternoon, Mr. Gething. I represent 13 pregnancy, parent and baby organisations. I'd like to ask you, if I may, about some of the experiences that disabled pregnant women faced. Ms Carey briefly touched on the Locked Out report commissioned by the Welsh Government's Disability Equality Forum. Paragraph 3.25 of that report concluded that maternity provision was uneven across Welsh health boards during the pandemic, with particularly significant impacts on disabled women. And the report gives as an example difficulties that disabled pregnant women had in conveying their genuine needs to be accompanied by an advocate or a partner when visiting restrictions were in place. It also highlighted that the provision of afterbirth care by phone was particularly difficult for those who were deaf or had hearing loss. Recommendations were made within that report and included the suggestion that women be allowed to self-register their requirements and that requests for reasonable adjustments are properly formalised to allow for proper consideration of whether a partner or advocate is needed at appointments. My question, Mr Gething, is this: what specific measures, if any, were put in place to monitor health boards to make sure that they were identifying those women and pregnant people who needed additional care and support?
I think there are 2 points. The first is that the reports were published after I was Health Minister, so taking forward recommendations would have been for my successor. And the first is, in the detail of the question you're asking about the government monitoring that level of detail, that would be pretty unusual. And you'd have to have a system in place to do that with lots of reporting. What we expect is the cultural point about how you listen to women, and that the voice of the mother matters about preferences and requirements. The 2 are different, of course. So, but to understand what that means in terms of having the best birth experience possible. So, culturally, I'd expect that's what we should do. And there's been quite a lot of work done with midwives in particular, who want to lead on that cultural change happening for every mother, including disabled mothers as well. So, but there isn't a specific monitoring programme in place for disabled mothers. The monitoring and oversight does come from the Chief Nursing Officer, leading with the Chief Nurse and Chief Midwifery Officer as well, and what is happening in health boards. And we've intervened in health board areas where we've not been satisfied with practice.
Thank you, Mr Gething. Thank you, Melanie.
Mr Thomas, give me.
Good afternoon, Mr Gething. Can you see and hear me?
I can see and hear you now, yes.
I'm representing FEMHO, the Federation of Ethnic Minority Healthcare Organisations. At paragraph 160 of your statement, you note that the risk assessment subgroup concluded that a combination of various factors contributed to the severity of infection, including age and ethnicity. Following this conclusion, were any targeted public health interventions introduced specifically to address health inequalities linked to ethnicity during the pandemic?
No, so in my statement I point out that the risk assessment tool was introduced. So this leads from our understanding from the letter from Bapio, in particular, saying there are problems, and there is a disproportionate impact in some ethnic groups. So that's why action is then taken. The risk assessment tool is provided. On the wider public health challenge, we started the pandemic, not where I'd want us to be on public health anyway, and since then our challenge is how we invest in public health and improving public health outcomes. So I'm not sure if you're asking about wider public health determinants in the population, or if you're asking about staff and the work that we did do with the risk assessment tool, where ethnicity was a particular factor, and the fact that we knew that it wasn't even. Not every black and brown person had the same risk, but if you look like me or you're at a heightened risk compared to some member of the white population. Slightly less risk if you're from different ethnic groups, but still often a higher risk than the general population.
Okay. Given the subgroup's findings, do you believe that addressing health inequality, structural racism and variability in healthcare outcomes should form a core part of pandemic strategy planning going forward in the future?
I think it would be sensible to look at those existing healthcare inequalities and the disparity of impact between different ethnic groups. That would be very sensible to do. Even more sensible would be to have this as a standard part of business in the way our healthcare system and wider society works. We know there are different outcomes that are not explained by ethnicity in a positive way. If you think, for example, about the different experience of black and brown mothers in childbirth, that isn't to do with the pandemic, but those things can be exacerbated in the pandemic.
Okay. Let me move on. Just coming back onto the subgroup's report, paragraphs 163 to 164, you highlight the disproportionate impact of the pandemic on ethnic minority communities and the importance of capturing ethnicity based data, including on death certificates. Question, once ethnicity-based data becomes available, how was it used to inform decision-making during the pandemic?
So the wider ethnicity data and the improvements didn't really take place in the pandemic. If you look at, I know you've read the statement, it talks about things that are being done afterwards as a result of the report. What we did know, for example, was, I think I mentioned earlier, taxi drivers and bus drivers as occupational groups outside the health service with the highest rates of mortality. Some of those about comorbidities. There is an ethnicity factor in that as well. So what we're then looking at is how do we make sure that there are measures in place to protect different groups. Taxi drivers, for example, we helped cab drivers to have perspex screens, provide an extra barrier for them in place whilst going about their work. The risk assessment tool is an example of what we did in the health service, but it was then adopted in wider public services in particular, including non-devolved services. Police services in Wales were interested in the risk assessment tool and how they could adapt and use it as well to try to make sure that people could still be in work but redeployed to areas that took account of their risk.
Okay. I think you may have touched upon my next question, so I'll skip over that and come to my final area, if I may. And this is on engaging with minority ethnic communities. Did the Welsh Government actively engage with the Black, Asian, minority ethnic healthcare workers, health organisations and community leaders to ensure that information about COVID-19 prevention, treatment and healthcare guidance was communicated in a culturally sensitive and accessible way?
We did at various points in time. So not just the work of the subgroups that Professor Ogbonna and Professor Keshav Singhal chaired to deliver the risk assessment tool, but that engagement took place, and I'll give you examples. When we were looking at vaccination, understanding the different cultural sensitivities around vaccination, around different faith groups, around ensuring that people could have confidence they could take the vaccine, and the work that we did, not on a national campaign, some of the discrete campaigns we ran were about making sure that people didn't just have confidence in the service, but we could understand the fears and concerns that people had. None of that is perfect. I think there are times where other commentators make the mistake of thinking that ethnic minorities are a single community, as opposed to a range of different factors you need to take account of. That doesn't mean that we're hard to reach, because we're pretty obvious. It means you've got to make an effort to talk to us in the way you talk with the wider population. And so we definitely did do that. And perhaps that example around messaging around vaccination is the best example of a specific communication to try to be culturally sensitive. But I'm always ready to listen and to learn. If
Okay, well, let me come on to my last question, and it's this. Based on your experience, how could this approach be strengthened to improve engagement and outcomes for minority ethnic communities in future public health emergencies? What can we do better? What can we do better?
I think you've got to fix what we do every day, because in the pandemic, it's under more stress and strain. You're making extraordinary choices at a pace that no one's comfortable with. But actually, if you still have a problem with engagement in the first place, if people think, I'm not sure if I trust the health service in the same way someone else does, if you think, if I go into labour, will my choices be respected in the same way as another mother next to me? That affects not just how you feel about the service, but it affects outcomes as well. And one of the things we definitely need to do is we do need to take a more serious approach to public health inequalities, because they map onto socioeconomic inequalities and they map additionally onto race inequalities as well. So get that right, that I think actually you're better geared up to properly deal with a pandemic and recognise in lots of infectious diseases there will be a different effect for different people, not just age and comorbidities, but race is definitely going to be, I would be surprised in a future pandemic if race isn't a factor, but the least you need to do is to consider it at the outset.
Thank you, Mr. Giffen. Thank you, Melody.
Thank you, Mr. Thomas. Mr. Vakumara. Oh, it's you, Ms. Hannett, is it? Sorry.
Sorry, my lady, there's a degree of confusion between my junior and I, but I'm asking the questions this morning. Mr. Gething, I appear on behalf of the long COVID groups. We're very grateful to Council to the Inquiry, who's asked a number of the questions for which we have permission, so hopefully I can take this relatively shortly. In particular, I wanted to ask you questions, if I may, on long COVID services. You referred this morning to the rehabilitation framework, and in particular in January 2021, you were provided with ministerial advice on long COVID, which stated that health boards will need to avoid over-medicalising people and avoid referrals to unnecessary investigations and increasing unnecessary demand on secondary care. Were you aware that the advice in that ministerial advice prioritising rehabilitation and discouraging referrals for clinical investigation conflicted with the NICE guidelines, which recommended clinical management of symptoms of long COVID?
I'm not sure that's a fair characterisation. One of the things we've tried to do, in particular on the journey to having a more prudent healthcare system, is not to over-medicalise conditions where they don't need to be. That doesn't mean that appropriate clinical and medical interventions should not be undertaken. So I'd never considered the advice to say, where medical treatment is appropriate, don't do it, try to manage those people away, but it is about how you try to manage the reality of people's symptoms and how rehabilitation, often therapy services, can help to do that effectively. So with respect, I don't accept the characterisation that you're placing on the advice I received.
You referred also this morning to discussions with patient representative groups, and at meetings with the Welsh Government in February and March 2021, so a little after the ministerial advice we've just discussed, Long COVID Wales raised concerns about the management of long COVID and asked for long COVID clinics to be provided. Why wasn't the decision not to open long COVID specific clinics revisited when those concerns were raised?
In listening to people, you have to understand what they're asking for and why, and what you can deliver in the service to deliver the best sort of outcomes. Trying to co-produce a model doesn't mean that one particular side has a veto. And it's still about, is a specialist clinic model the appropriate model to deliver the best care across Wales? I wasn't persuaded that it was, neither were my advisors, and I know you've had evidence on this from Judith Paget, but it's still about learning. At what point is a specialist intervention appropriate, and where should that be? Does it need to be in a named long COVID clinic centre, or is it actually about how our service as a whole understands the needs of the population, including people living with long COVID?
In that respect, in this inquiry, Professors Brightling and Evans, who are the inquiry's long COVID experts, have given evidence that they recommend one-stop clinics in Wales, in other words, specialist long COVID clinics, because the complex and novel multi-system nature of long COVID requires access to a cluster of skills and knowledge in specialist clinics. So on reflection, in the light of that evidence, do you agree that it would have been appropriate to introduce one-stop clinics in Wales?
I think it's appropriate to look at the evidence and then for that evidence to be put before a minister to make a decision. I'm not going to try to insert myself as a clinical decision maker. I used to be a lawyer, not a doctor, and I'm certainly not a clinical expert now. But it's one of the things you have to do as a minister is where there is more than one clinical point of view, you have to consider advice and make a choice. And that is a choice for the current Health Secretary here in Wales.
Thank you, Melody. Thank you, Mr. Gethin.
Thank you very much, Ms Hannett. I think it's Ms Shepherd next.
Prynawn da, Mr Gething. I appear on behalf of COVID-19 Bereaved Families for Justice Cymru. I'm going to start off with the critical care questions and the evidence that you gave earlier, which was that the system did not become overwhelmed. You also said that an indication of an overwhelmed system is people not getting the care when they needed it. The families that I represent have given examples of their loved ones not being escalated to the level of care they believe would have saved their lives. In particular, Paul Jones gave evidence in this module that his daughter Lauren was not escalated from CPAP to ventilation and then to ECMO because there was insufficient capacity in the system for her to have access to that treatment. That's just one example. Do you agree that your statement that the system was not overwhelmed is from looking at the data you received, but it may not be reflected by the situation on the ground?
Well, I think we had the anecdotal evidence that was brought before me today, where a clinician said that they were making a choice, where they might have made a different one in normal times. Now, I think it's important to reflect on that and what that means. But I never had an instance brought to me where inappropriate choices had been made and that affected outcomes. Being sensitive and understanding how people have suffered loss and bereavement and the question of if something else had happened, would my loved one still be here, is important to reflect in a way that's sensitive and understands how our whole system works. So I don't think that changes any of my evidence or the importance of learning from what really did happen.
Professor Fong gave evidence to the inquiry that the data does not tell the whole story and that it does not always reflect what was happening on the ground. You mentioned the example that was given earlier from the critical care doctor. If no equivalent study to that of Professor Fong was conducted in Wales, how were you as Health Minister able to understand whether the data you were receiving gave you an accurate picture of the pressures on the ground?
Well, the picture of pressure on the ground is partly driven by the data, but it's also the direct conversations and reporting that take place as well. That's with the Chief Executive of NHS Wales, the Chief Medical Officer, the Deputy Chief Medical Officer, with the Chief Nurse, with the Chief Scientific Advisor on Health, the Therapies Advisor, the Chairs and Chief Execs, a direct engagement with trade unions and medical colleges. There's quite a lot of information that isn't just about data, but is about experience and what people are doing on the ground. And as a minister, you have to try and understand those things and still make choices. The data is always going to matter, but I wouldn't disagree with the view that it's not the only thing that matters.
Dealing with the data then, at page 78 of your witness statement, you provide screenshots from the daily NHS update showing the critical care capacity in Wales. Did that data show you whether there was the staffing, medicine and other necessary equipment to go with those beds?
No, that would have been a separate report. And again, when you think about staffing, you're thinking about what responsibility do I have, what responsibility does our system have, and how are we making choices about how the whole system operates. So the compromises you make on turning off other parts of the system so you can redeploy staff to make sure the beds are staffed properly in this environment. It was never the physical bed that was the biggest limiting factor. It was always the staff to deliver the care. And it's also about understanding the additional pressure you're under, which is why I changed the reporting on how you reflect current potential capacity against normal capacity, show the flex that has been used, and that reflects other parts of the system that are not operating as well.
Do you agree that just because the global figure across Wales for critical care beds was not breached does not mean that all patients received the treatment that they needed at the relevant time?
No, I think you're conflating two quite different things. The global figure not being breached showed that we had more capacity to surge into. Whether people got the appropriate treatment is actually a matter about what was taking place with and for that person. And even in a time where capacity is not breached, it's possible for people not to get the care that they need. In the pandemic, and understanding what we were doing and why, it was never brought to my attention with an individual example or a complaint from not just leaders, but the different groups that I met with, that people were not getting critical care they needed that would have made a difference. That doesn't mean it didn't happen, but it certainly was never brought to my attention as far as I recall, Council.
Thank you. I'm going to move on to testing now. At your paragraph 304, you confirm that you announced the policy of routine testing of asymptomatic healthcare workers on the 4th of December 2020. The UK made that announcement over 2 weeks earlier on the 16th of November 2020. Why was there a delay in Wales?
Sorry, you said about the 16th of November?
So it was the 16th of November when it was announced in the UK, in England, and it was the 4th of December in Wales.
Oh, I think you've had an answer on this from previous evidence about LAMP technology being used in England that we didn't have in Wales. So we're able to do this when lateral flow devices were in large number. And I think if you look at paragraph 303, I point out the Chief Scientific Advisor had been providing updates on the mass testing programme and the availability of lateral flow devices. So if we'd understood that lateral flow devices were not going to be aware anytime in the near future, we might have had to make a choice to invest in LAMP, which I think is a laboratory form of technology, and the staff to do that. That would have meant investing in infrastructure and in staff to do that. That wasn't a practical thing to do within 2 weeks. When we did then, though, get access to reliable lateral flow tests, that's when the choice was made because we could deliver it.
And although that rollout was due to be rolled out in full from January 2021, evidence has been provided to this inquiry, particularly from Professor Clare, that it was not in fact rolled out until mid-March and as late as July 2021 in some cases. Do you accept that that was an unacceptable delay?
Yeah, I was surprised by that evidence because I would have expected for something like that I'd have been made aware and that Welsh Government officials would have been aware as well about the fact that there was a different choice being made. As far as I recall, nobody came to me and said, this isn't happening and nothing's been done about it. So I was surprised at that part of the evidence from Dr. Clare.
A follow-up question on that. Did you do anything to investigate into whether the testing regime was being rolled out in a timely manner by the health boards?
Well, I saw all the figures that were coming in about the large numbers of tests that were being done and the availability of workforce. So I could see that more and more healthcare workers were getting tested and what that meant in terms of the availability of staff. And that's particularly important as you move into what was a high prevalence time and a rising tide of COVID infections through December into January. So understanding that staff are able to work and have negative results is really important.
If I could have up on the screen, please, 349686. Just to locate you in this document, it's the report arising from the Senedd Social Care and Sport Committee's inquiry into the impact of the COVID-19 outbreak and its management on health and social care in Wales, and it's dated July 2020. A number of recommendations are made, and in particular at page 45 of this document, we have recommendations 7 and 8. Recommendation 7, the Welsh Government, working with NHS Wales, must develop a clear plan for regular and repeated testing of health and social care staff, including asymptomatic staff. And I won't read out recommendation in full, but it sets out some steps to be taken to ensure that there is sufficient testing capacity. Given that the regular testing regime was not in fact rolled out until spring-summer of 2021 in some cases, do you agree that there was a failure to carry out these recommendations?
Well, making a recommendation is one thing, but you've actually got to be able to do it. And, you know, the scrutiny is about a challenge for the government. That doesn't mean that you can automatically deliver testing capacity. And I think in evidence you've heard about how Lighthouse Labs in particular went through phases where they were reliable, increased capacity, but actually there were also times where there were real problems that affected the care home sector in particular. So delivering testing and repeat testing for health and social care staff is a practical challenge that simply making the recommendation doesn't actually help you to deliver. And we didn't actually have the tools to be able to deliver this in the way that's envisaged until lateral flow devices were available. I wish they were available earlier, but the simple fact is that they weren't.
I'm going to turn then to my last topic of questioning, which is the NHS estate and infrastructure. The Chief Information Officer at Cymtarf is critical of the inability to extract data from NHS systems in Wales and states that by the 24th of March 2020, daily laboratory reports were available for NHS sites that could be linked to other hospital datasets, but no consideration was given to differentiating community from hospital-acquired infection. Do you agree that the data collection and processing systems in Wales were insufficient to meet the demands of the pandemic?
Well, every part of our system had to shift. And so for the pandemic that we faced, what we had, it wasn't sufficient when we started. And look, I think the information officer is a high-quality public servant who's making a point around what we need to do to improve. And that's the point of it, isn't it? About how you understand what you can't do, but will help you to deliver something better. So not being able to link those different parts was important for us to understand healthcare-acquired infection and community infection. Not the only thing, but it would certainly have helped us.
You spoke earlier about the challenges that the ageing NHS estate in Wales posed for ventilation. When the pandemic struck in January of 2020, you'd had a health portfolio since September 2014. What steps had you taken prior to the pandemic to improve the ageing NHS Wales estate?
Well, we'd undertaken a number of investments. So the way that healthcare capital works, and I think Dr. Goodall's given you some evidence on this as well, is both the amount, but then how it's then allocated. What the government supports and allocates with business cases that are made to us by health boards and discretionary capital that health boards themselves use. Now, that is really often about maintenance. And, you know, there's a significant maintenance challenge in the estate because of the amount and the age of the wider estate. There are some investor save opportunities as well, and those normally require approval at a ministerial level too. But those are more often about delivering a more efficient service rather than spending more money to keep the service running and to deliver improvements in it. So once I'd made the choice early in the term to approve the Grange University Hospital, an awful lot of our available health capital had been spent. So the size of the capital we have available to us helps to govern the sort of choices we can make. I think in Glangwili, for example, I'd overseen and agreed capital expenditure on improving neonatal provision there. That was particularly useful when it came to parts of the pandemic, but that wasn't the reason why I'd approved it. So in each of those areas, you have to make the best choice available with the resource you have. And as you know, our capital budgets have been reduced in real terms and in cash terms at various points in time overall during my time in the government. And that's the unavoidable truth of the matter. I wish we had more money, but we did what we did with the funds we had.
Those are the long-term measures. What urgent measures did you take to minimise the impact of the ageing NHS estate on the ability to implement IPC measures during the pandemic?
So I think, again, you've had evidence on this from others, including Dr. Atherton and Jean White, an example being introducing perspex screens. And that's because if you think about, and I go back to going to have evidence on this, Glangwili Hospital is the oldest district general hospital in NHS Wales. So you compare that to the Grange Hospital, you've got individual rooms where infection prevention control should be a much easier thing to do in terms of the shape of the estate. Now, you can't simply build a new hospital without having the money to do it, and you can't simply say we're closing Glangwili during the pandemic. So to do that, you've got to compromise, and so the perspex screens that were installed were a compromise to try and improve IPC practice to have separation between patients. You've also got things like the way that washing facilities are delivered and shared. So as our estate's been modernised and retrofitted, you'll see improved IPC practice, for example, in the new Prince Charles Hospital. Well, I say new, it's been significantly refurbished, still on the same footprint, but the changes in the layout should improve patient experience and IPC, as well as new services that were not envisaged when that hospital was originally built.
This morning you discussed how there isn't a control and command arrangement in Wales. Do you think that the Welsh healthcare system setup, namely where the health boards and trusts have sovereignty and operational control, led to difficulties in ensuring implementation of IPC measures across all health boards and trusts in a uniform manner?
I think the challenge is if you simply say we'll have a central command and control where someone in Cardiff will tell everyone what to do and then they must do it. You can do that with directions. It doesn't mean you get compliance. It doesn't mean you get good practice. It doesn't mean you get the culture you need in organisations. I think our model is broadly the right one, but it is how you make sure that model works. How, when people are making different choices, they're clear about the fact they're making different choices through their own executive infrastructure and at board level. And on issues like this in the pandemic, how that is properly communicated to Welsh Government so it doesn't end up being a surprise. It doesn't mean that will be the wrong choice, though. When we come back to some of the questions I was asked earlier, the situation in Withybush in Pembrokeshire was markedly different to the situation in Wrexham Myler at various points in the pandemic. Trying to tell people what they must do, regardless of local circumstances, is not something that can always work. On IPC measures, though, I think the rigour that is attached to those is something where you still are going to need local leadership and local, not just expertise, but local cultural agreement that that's the right thing to do for staff and patients, even if I made all those choices in my office in Cardiff.
Diolch yn fawr, those are my questions. Thank you, my lady.
Thank you very much, Ms Shepherd. Thank you very much indeed, Mr Gethin. It's obvious you spent some time preparing to give evidence, and I'm really grateful to you for taking that trouble and for helping us today. I can't guarantee we won't ask you to come back, but I promise you we'll limit the burden we place on you as much as we can. Thank you for your help.
Diolch yn fawr iawn, my lady. Thank you.
Very well, I shall return at 1:55.